Testing, testing. 1, 2, 3, 4. Testing, 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 testing. Testing, testing, testing. 1, 2, 3, 4, 5, 6, 7. Testing. Kevin. Done. Keep going. 1, 2, 3, 4, 5, 6. Welcome. Me. Testing. Hello. Yes? Okay. Testing. Yes? Kevin? Yes? Okay, keep going. Well, uh, that's better. Testing. Testing, testing. Okay.
all take our seats so we can get started? Just a few people at the back just moving in. So welcome everybody to the Business School and to Imperial College and to the Business School's second Mobilising Business Conference. I'm going to be chairing the session along with my colleague Lord Duprat all day. By the way, I'm James Barlow. I'm a Professor of Technology and Innovation Management in the Business School, specialising in healthcare. Laura and I and the wonderful conference team have been responsible for putting this programme together for you. Before I introduce James Sterling, I just have a few housekeeping announcements to make. And I believe there are some housekeeping-related slides here. No, those are my slides. Could I just have the housekeeping slides? But anyway, no fire drills are planned. If there's an emergency, that's the number to dial, not 999. But there'll be plenty of people from Imperial College to look after you. And you need to do the usual things. But basically, follow Imperial College staff to the assembly point, which is outside the building and sort of round the back. But hopefully we won't need this. I don't know if anybody's got a personal evacuation plan, but I don't think I've got one, but we probably should have one. And if you can tell, if you can read that map, you're better at geography than I am. So anyway, with that, I'm going to hand over to James Sterling, who's the Provost of Imperial College, who's going to just say a few words by way of opening, and then you'll hear from me for a few minutes before we get proceedings underway. So, James.
Okay, thank you very much, James, and I'd like to add my words of welcome to you all, a very warm welcome to what is the second annual Imperial College Business School Conference this year on mobilising business, acting on future health. It's great to see so many people here today on what we're told is the warmest day of the year so far. Ah, well, okay. Okay, now James will say a few words in a moment about the context and the purpose of the meeting. But it's clear that what you're talking about and listening to today is indeed one of the most serious and urgent societal challenges, effective and affordable healthcare for all. And to say that this is timely is a massive understatement. Here in the UK, the future of the NHS is in the newspapers every day. In the US, healthcare has become a political football. And meanwhile, the provision of affordable healthcare in the developing world is reaching crisis point. And all this against a backdrop of other great global challenges such as climate change and antimicrobial resistance. Now, Imperial College's strategy says very directly and very explicitly that we will focus our research and education mission on these great global challenges, and we will do this. We will do this by multidisciplinary work that builds on our very strong disciplinary foundations in science, engineering, medicine, and business. Indeed, the ability to work seamlessly across academic disciplines is, I think, one of the key strengths of Imperial College. Our strategy also makes clear that we cannot solve these big problems alone, that we do need to work with partners, be that partners in other universities, partners in business and industry or other public sector organizations. Only by working with partners will we succeed in our mission. And I'm delighted, therefore, to see so many organizations represented here today. Some of you, of course, are already very valued partners of Imperial, but I hope that from your conversations and discussions today, new partnerships will emerge. Imperial is very much open for business. I just want to finish with a few words about our host, the Imperial College Business School. It's a relatively new business school. It spun out of the Faculty of Engineering not so many years ago. But in those few short years of its existence, it has become one of the world's very best. Because it offers a unique proposition, I think. It's arguably located in the world's most international city, and it is part of one of the world's leading universities. So it is able to work in harness with some of the world's best engineers, medics, and scientists, and I say that gives it a unique position amongst business schools. It has also benefited from excellent leadership in recent years, and I would like to take this opportunity to thank Professor Nelson Phillips for the outstanding work he has done as acting dean in the past year. He has taken, in that short time, he has taken the school forward and has done much to further strengthen the links between the business school and the other parts of the college. So thank you, Nelson. This summer, Nelson will hand over the leadership of the business school to our new dean, Professor Francisco Veloso, who's currently the dean at the Católica Lisbon School of Business and Economics in Portugal. And the school will embark on an exciting new chapter in its development, and I hope that you all will be part of that. So it just remains for me to wish you an interesting, productive, and enjoyable day. I'd like to thank the conference co-chairs, Laura and James Barlow, for their excellent organisation work, and thanks to all of you for attending. Thank you.
Thanks, James. Yes, I just wanted to say a few words just to set the scene, really, for the conference and this series of conferences as well. This, as James said, this is the second in our Mobilising Business series. We created that series because, as a world-leading business school, our interest really is in the big global challenges and the way business, academia, policymakers can come together to try and tackle those. Last year, the conference was about climate change, and that was in the wake of the Paris conference. And clearly, climate change is possibly the greatest global challenge. But I think delivering healthcare to as many people as possible, at as high a quality as possible, and as affordable and sustainably as possible is perhaps the second biggest challenge. So I think it made sense that we organised our second annual conference around the global challenges of healthcare and how business can contribute to addressing those. We're launching a new Centre for Health Economics and Policy Innovation in May, and we'll perhaps hear a little bit more about that later on, but the director of the centre is Franco Sassi, who's sitting here. But the new centre is really going to be dedicated to addressing these big issues. And I mean, I'm not going to overburden you with PowerPoint slides. I've just got 3, I think, or 4. But I think it's worth just picking up some of the points that James made and just getting us all to think about what those big issues are. And first of all, of course, aging. Billion extra people aged over 60 over the next 35 years. Well, I turned 60 in January, so 60 is not old, but 300 million of those will be over 85. So aging and all the associated challenges of that is clearly one huge problem, or huge challenge for both developed and many parts of the developing world now. Franco is an expert on obesity who worked in the World Health, in OECD, and about 2.1 billion people in the world are overweight, nearly 30% of the population globally, and about 600 million are obese. So again, big problems for health systems associated with that. And then James mentioned AMR, antimicrobial resistance. The O'Neill report suggested it might cumulatively cost the world's health systems $100 trillion, I think it's $1 trillion, yes, $100 trillion over the next 30 years or so. And I think the number of deaths from AMR was projected in that report to rise to about 10 million a year if we don't do anything about it. So big issues. And where does business fit into this picture. Last slide. We spend something like $8 trillion a year globally on healthcare, and about $2 trillion of that is on the inputs, the drugs, the medical devices, the IT, and the built environment for healthcare. We spend as much on the built environment as we do on medical devices. So clearly, business has a huge, huge role to play in tackling these global challenges. But there are big issues for business as well. We know we need innovation, but innovation is hard. It's difficult. It's difficult for businesses. Certainly the drug industry I was talking to Chaz Boontra this morning about picking off the low-hanging fruit, and now it's the really difficult stuff that needs to be dealt with. And increasingly, medtech is facing the same challenges. So we need to rethink what we mean by innovation and how we do it from a business perspective. And we'll hear from Rebecca Fogg from the Clayton Christensen Institute this afternoon about disruptive innovation, delivering affordable, simpler, good enough solutions, and what that means in healthcare. And of course, from the other side of the coin, from the perspective of policymakers, healthcare providers, innovation is a bit of a double-edged sword. You know, we know we want it, we need it, but it costs money, and a lot of technological innovation in healthcare actually increases our ability to do things and rises costs. So innovation is an issue, and it takes a long time for many innovations to become embedded in practice, as I'm sure a lot of you in the room are well aware of. So the task today really is about tackling these big global healthcare, health system, health policy challenges largely from a business angle, but clearly business doesn't operate in a vacuum, and we need to think about the financial and policy implications as well. In the last year or so, I've spoken at pharmaceutical industry conferences, medtech conferences, healthcare built environment conferences, but it's very rare to get everybody in the room together, and people from the finance side as well, to get them in the room at the same time. So I think I'm very pleased that we have representation from right across the board, and including some people from policy background as well. So it's going to be a fascinating day, I know, and I hope you're going to enjoy it and get a lot out of it. So that's enough from me. I'm now going to hand over to Mark Britnell, who's our keynote speaker this morning. Mark is chairman and partner of the Global Health Practice for KPMG, and he has a book, which I've just been told it won the 2016 British Medical Association Award for the best health and social care book.
That's a recommendation.
And Mark has worked all over the place at national, local, regional level. You can read about his CV in the course book. So, Mark, over to you.
Can you all hear me? You all see me? Yeah. Bad luck. Okay, I'm fine. Thank you. I'm fine. Thank you. Good morning, everybody. I'm Dr. Mark Britnell. I'm the Global Chairman for Healthcare for KPMG. As you can see here, I'm also one of the 15 members of the World Economic Forum Health Council. And every year we get the opportunity, 15 of us, to try and speak truth to power in Davos. And this year we produced a document. Some of you may have seen it. I don't think it's been widely circulated. But my colleague at Harvard, Professor David Bloom and KPMG, decided to test a hypothesis. And if you don't remember anything else I say in the next 15 minutes or so, I'll leave 5 minutes, James, if that's okay, for Q&A. Our central hypothesis is we can do more good for the world in terms of accessible and affordable healthcare if we change our business models and adopt new therapeutic and technological advances. And that hypothesis was tested over 18 months with our global healthcare team. I'm not going to plug KPMG. We've been going for 140 years. We operate in 157 countries. And basically, oh, did I? I'm so sorry. Basically, with Harvard and a central coordinating team from the World Economic Forum, we produced a piece of work which we used to try and challenge the prevailing political consensus. Now, we all know that healthcare consumes more resources every decade or so in the developed world. GDP rises by about 1.4% every decade to accommodate advances in therapeutics, in technology, and indeed, as James said, aging. But when you look at misalignments in healthcare, and when I refer to misalignments in healthcare, I mean the misalignments between payer, provider, pharma, and patients. When you look at those misalignments, the waste in the system is truly phenomenal. Now, before I show you our two key recommendations or insights, I just want to make sure that we're all broadly on the same page. Of course, we should celebrate longevity. It's one of the greatest, I think, achievements of humankind. But equally, as we age, of course, that places into stark contrast some of the failures in systems and nations around the world. And as you can see from this slide, whilst our life expectancy has increased by 25 years globally since the end of the Second World War, we still have life expectancy of 45 or 46 in Sierra Leone, and of course in Japan at 84 or 85. Interesting to note that the South Koreans have just taken over the Japanese for the world title for the longest living population. We also know that lots of people die prematurely, and I don't need to tell this audience that that's a blight on humanity. But when we started to think about what produced some of this misalignment, we decided to go into deep discussion with our private sector partners, our public sector partners, NGOs, and also charities. So the hypothesis, as you can see here, is that misalignments among stakeholders significantly contribute to the underperformance and waste within the health sector. And Adrian Goy, some of you may know him, a very influential oncologist and cancer doctor in America, also a member of our World Economic Forum Health Council, describes misalignment as fundamentally a disconnect between the interests and objectives of different stakeholders and players. No surprise there. But once again, just to reiterate my central point today, if we all know that's a truism, why don't we spend much more time, effort, and research on reducing those misalignments? Now, I'm not really going to plug my book today. It's a bestseller. We have left 20 copies upstairs if you want to get one for free. If you want to pay for one, I've waived all of my royalties to Prostate Cancer UK. So if you feel good about yourself, go buy the book. If you don't, you feel cheap and nasty, just take one upstairs. Now, the reason I mention that is, as you could see from my first slide, I've had the privilege of working in 69 countries. And one of the chapters in my book is called The Paradox of Change. And fundamentally, I make a very obvious point, which is if you can better align payers, providers, pharma, patients, and others, you get much more value in the system. Now, what we did to test our hypothesis, and you can see that we also discussed and talked to Imperial College, we spent 18 months conducting 60 interviews in 16 countries across 6 continents. So as far as you can get a global sweep from different stakeholders in different parts of the world, we had a very good go at it. Now, what's interesting, of course, when you have these interviews, somewhat detached, admittedly, from the hurly-burly, the cut and thrust of paying or providing or regulating healthcare, people tend to be a little bit more honest. And these misalignments, as you can see here, I'm not going to go through each one of them. I'm sure in your own professional careers you bumped up against at least, if not all of them, certainly the vast majority of them. And we talked and modelled 3 different care diseases to see what the benefits of alignment could produce. And the 3 areas we looked at were cancer, diabetes, and mental health. So we didn't choose necessarily the easiest ones, nor indeed the sexiest ones arguably with mental health being included. What were our two major conclusions? By the way, if you're interested in the research, it's on the World Economic Forum website. We concluded two things. The first one, I don't know whether you'll find it that surprising, although personally I was surprised. The second one I think is a little more stunning. The first one is that when you look at cohorts and deciles of spending groups of countries, and you basically assume that those spending groups in those deciles can raise to upper quartile or upper decile performance. So I'm not arguing that Sierra Leone can ever be the United States of America. We're taking basically similar countries with similar health profiles, with similar health patterns of provision, and we're saying, what if they raise their game to the upper quartile and then the upper decile? And the conclusion we came to, and this was work that David Bloom did with his team in Harvard, supported by our economists from KPMG, the conclusion is you can get, on average, an extra 4 years of life if you improved each cohort, each national cohort's performance. Now, of course it's abstracted, of course it won't happen, but by asking that question, instead of always thinking that we need more of everything, why don't we think about innovation in business models that get more out of what we've got? If we did, and that doesn't seem to me to be an unfair or unreasonable assumption. And another matter I raise in my book, I don't know whether I mentioned my book or not this morning, is we, of course, in KPMG, we span 21, 22 different sectors, but the degree of competition and collaboration in energy or telecommunications or pharmaceuticals or indeed academia for that matter is much greater than the degree of collaboration in global health. We have great, fine global health institutions, Bill and Melinda Gates, the World Health Organization, but no institutions really exist or dominate this quest for better business processes and care models across the world. Changing American healthcare systems, for example, we're working in New York State, 21 million people, trying to create accountable care. The mechanisms and principles for doing that are just exactly the same as doing it in the Netherlands, or indeed doing it in Singapore, or indeed in the United Kingdom. So the conclusion, the first conclusion of our research, it's all, I think, meticulously documented for those that want to read the document, the paper, is that if we raise performance to the upper quartile and then upper decile, we would, for the same amount of money, it's about 9 trillion now, but we won't quibble, 7.59 trillion, we've been talking for at least 10 minutes, is 4 years of extra life expectancy for all human beings on the planet. Now that's worth having. The second conclusion, I think, is more stunning. If you wanted to maintain the same life expectancy globally, you could do that for 33% or a third of the current costs. Now, I'm not clearly arguing, by the way, a lot of the waste is in the United States of America, so that skews it quite considerably. I'm not obviously arguing that the United States should give 2/3 of its health expenditure to Sierra Leone, but I am making the point that if you wanted just to maintain, you could reduce costs and eliminate waste by reducing divergent interests and stakeholder misalignment. So, the three areas that we concentrated on, looking at, as I said, cancer, diabetes, and mental health, were these three areas. And these three areas account for a lot of waste in any health system, both in the developing and the developed world. Divergent objectives, power asymmetries, and cooperation failures. I know of no health system, unfortunately, possibly with the exception of China and Singapore, for completely different reasons, that thinks anywhere beyond 3 years in a cycle of health, reform, and innovation. It's a very sad fact. Health, as you know, when coupled with life sciences, is the second largest industry on the planet after agriculture. And it stuns me that we have no critical thinking of any seriousness that extends beyond 3 years. So the first point to make is there is no long-term sustainable vision for how misalignments can be reduced. You can argue that Obamacare, for example, tried to have a go in the United States. You can argue that the 5-year forward view is trying to have a go in the English National Health Service. You can argue that the new clustering arrangements in Singapore are thinking about the future in terms of ageing. But there is no country that really can hold its head high when thinking about systematically reducing these misalignments. So in my own humble way, I call in my book for a new global organisation, perhaps it can be facilitated and powered by Imperial, to think about exporting best practice in business model innovation. We do it in plenty of other sectors, including financial services. Why shouldn't we do it for the second largest industry on the planet? You can see here, and some of these slides obviously are bullish. They make very blunt points just to exaggerate my argument. So you look in the OECD, for example, in terms of health expenditure on cancer. It's not quite a case of they who shout loudest get most, but you can see what's spent in research is not what's actually killing people. Now, there are lots of different reasons for that. We all know the issue about smoking and lung cancer, but that's just a very simple point about where research is being misaligned from health need and health benefit and extended quality-adjusted life years. An easy point. The more profound point, as I say, is in the maroon behind me, where, and I'd ask you to think about this from your respective countries. We've got a pretty good spread today. Can anybody think of any country that's got a meaningful 5 to 10 year plan for healthcare, which combines the impact of education, crime, insurance, healthcare, governance, and the rule of law? It wasn't a rhetorical question. Any takers?
Yes, there are several actually.
Okay.
Yes.
Which one would you highlight as being probably the best?
Well, I think Turkey has introduced excellent health system reforms with massive reductions in health outcomes, improvements in financial risk protection and user satisfaction, and they achieved that just in a period of 8 years. Malaysia has just embarked on a very ambitious health system reform. I could go on.
Yeah.
But so there are several that are actually, and there are also those. I worked in a country that has a health strategy to 2050. What is the strategy?
Good. Well, on Malaysia, of course, that reform has been a long time coming, so let's hope that they're going to now expeditiously implement that after all of the political turmoil over the last few years. We wish them well. I'll put some money that they don't achieve their objectives, but we'll have that bet later on. Secondly, power asymmetries. You can see here that only, according to the World Health Organization, only 10% of the world's population live in a country with a tobacco tax, for example, that is sufficiently high to compensate for its social cost. And secondly, as I said here, you look at the funding behind different tumour sites, and there is a clear mismatch. Cooperation failures are, I think, probably the biggest example of asymmetry that I find when I go about my work around the world. And quite simply, there is too much short-termism between a payor and a provider. So there's no concentration on the pursuit of value. I know it's a hotly debated subject, whether you're a Porterite or some other right. Basically, the lack of, I think, systematic attention to the pursuit of value over, say, a meaningful period, which would be 10 years, I think is stopping us actually align incentives or sufficient incentives in the short term. And this is just one example here where we talk about cost shunting between health and social care. It's good that we've got Ian Smith here today from Four Seasons. I know that he's speaking later on. And clearly that's a big issue that's occupying the attention of policymakers and politicians in the United Kingdom at the moment. But equally looking at cooperation failures between clinicians and patients. So thinking about how far patients can actually help to cooperate with their physicians in taking more self-care into their own control and their own hands. Having said there are no countries, in my opinion, that have a systematic plan to reduce misalignments over a sufficiently long and sustainable period of time, I don't want to be too depressing. There are great examples of cooperations across the world. And here I just mentioned 3 or 4 of them, whether it's in Brazil, in Singapore, in Israel, or in Australia. And I haven't got time today, unfortunately, to talk about some of the more successful characteristics that I've seen. But one system that does very much impress me is the Israeli system. Now, as you probably know, in the early part of the 20th century, the sort of workers' movement in Israel created a number of health maintenance organizations. They, I think, are more sophisticated or smaller in scale than some of the more noteworthy ones in the United States. But if you take just one, for example, Keynote, that ensures 52% of the population of Israel. What is nice about their health system is that they have 4 integrated HMOs. So they're both payers and providers. And ever since about 1915, 1916, they have consistently invested in prevention and also in primary care. Now, there are problems with the Israeli system in terms of the pressure on its hospital sector. It has a very small, relative to per 10,000 population, number of acute beds. But their system is fundamentally established to think about prevention and primary treatment. And of course, the results, broadly speaking, 7.8% of GDP for average life expectancy of 83 or 84 years of age, stand up well and against good global comparisons. There are 2 or 3 other things that I just wanted to say about the Israeli system, which help to illustrate this issue about reducing power asymmetries or misalignments. The first one I would say is they spend a disproportionate amount of their national wealth on technology, partly because of the defence industry, which we all understand, but also because of care. 57% of paediatric consultations in Keynote take place on the smartphone. It's a good example of how you're reducing the asymmetries of power between a doctor and a patient, but also reducing that costly and fragmented supply chain. That's just one example. The second example is that most of their diagnostic capability is housed in community or ambulatory settings and not warehoused or fossilized in big teaching hospitals. And the third issue to say is that their research and development capability is closely connected to the economic prosperity of their country. Now, I'm not claiming it's perfect. You wouldn't believe me if I did. But they are thinking more broadly about the determinants of health and reducing some of the misalignments that cause waste in a health system. Finally, in my book, I say there is no such thing as the perfect health system. My second book will be called Still Searching. But what I tried to do here, and I can't go through these examples, is look at the 12 things that have struck me as being very powerful contributors towards a better, or indeed a near-perfect health system. In conclusion, if we could reduce some of the misalignments that stakeholders tell us they fight against or with every day, and if you generally accept that the work that Harvard and ourselves did in 16 countries looking at payers, providers, pharmaceutical companies and patient representative groups, my challenge today, or my question today, which I think hopefully fits with the theme of the conference, is of course we'll end up spending more money in healthcare. That's right and proper for every civilized country that's developing. But there is much more that we can do to reduce and eliminate waste to create better value in our health systems. And I would humbly call for better global cooperation in terms of looking at business models in healthcare that work, and think about academic and business and other groups coming together to make sure that we can perhaps more sustainably and more evenly spread what works across global healthcare. Thanks very much indeed.
Thanks, Mark. That was a fascinating talk and a great introduction to the day, I think. I know there are themes in there which we're going to pick up around business model innovation later on. So that was excellent. I think we've got time for just a couple of minutes of questions if anybody has anything. Yes.
So Mark,
Could you say who you are, please?
yes, Dominic Five, the Sound Horizon. So we're a boutique consultancy. We work with a variety of different players in the space, including pharma, government, and small wearables providers. So, first of all, there's a rumour that you've got a book out. You've just achieved a sale on Kindle while you were talking there.
Thank you very much indeed.
Power of immediacy.
Prostate cancer, thanks you.
So I wanted to just pick up on the cooperation failures that you outlined, and obviously there's a huge amount of waste going on there. With cooperation failures, a lot of our clients, people we talk to, they say that they would love to cooperate, but the medical establishment is surrounded by risk aversion, total and utter risk aversion. They're scared of even picking up the phone and talking to different players in the ecosystem. And I wanted to see if you had a perspective on that, first of all. And secondly, to ask you, do you think that the innovation that is necessary will come from outside of the health systems through small innovative players, as it is in financial services and entertainment and communications?
The answer to the first question, I'm pleased that Steve Smith's here with us today, Professor Steve Smith, who I think is a globally great example of an innovative clinician. So I would say, yes, by training, thank goodness, clinicians are trained to attend to the detail and think about risks. And I think as a cancer survivor myself, I'm pretty pleased that that attention to detail and that degree of risk aversion has helped save my life. However, I do believe it's possible to hold two different attributes in your brain at the same time. And fortunately, most clinicians are hyper intelligent. And therefore, I think it's about the way that they've been nurtured, not natured, in terms of actually starting to develop new cadres of clinicians. We know that our research scientists, that many of our clinicians that work with pharmaceutical industries have a high degree of restlessness and curiosity. So I don't believe that it's the clinicians that are the problem. I think it's the system in which they're educated and managed and work that actually destroys that over a period of time. I once had the privilege for 8 years of being the chief exec at the University Hospital Birmingham, and I remember my old medical director. I was 34 at the time when I was appointed, and my medical director was 62, so just older than you, James. And he said, the problem that we find with doctors in the English National Health Service, we appoint them at the height of their brilliance and watch them become bitter over 30 years. But enough about Steve Smith. Let's move on from that for now. But so I think it's about something we do to them and something that happens to them during the course of their career. So fortunately, the good news is there is quite a bit that we can do to rectify that. In your second question, when I was Director General of the National Health Service some years ago with Lord Darcy, of course, we looked a lot at innovation. And I think the simple answer to your question is you need both. You need a very strong government strategy, which does have some pump priming capability in terms of investment, but you do then need to create a much more fluid and I think permissive environment for startups and small businesses to thrive. And I have to say, honestly, with the exception of Silicon Valley and parts of the United States, Israel is the country that gets that right more often than any other country I've seen. Singapore's coming up, but the Israeli system is awash and alive with investment, technology and capability. So the answer to your second question is, yes, I believe you've got a very strong role for the future.
Good. Okay. Well, so many things to discuss, but so little time. And Mark, thanks very much. Are you? Do you have to rush off, Mark, or you
Stay for the next session.
stay for the next session? And okay. Well, we'll see you afterwards. So we now have a panel discussion, and we need our panelists to come down. So Rifat. Pedro is going to be chairing it. Pedro Rosadias, who's an associate professor here in the business school. Chaz Buntra, Jeremy Lower over there. And I think I'm just going to hand over to Pedro now to do the introductions.
No, of course.
Okay.
So, thank you very much for coming. This first session is on global health challenges, and we have an excellent panel and audience to talk about this exciting topic. It's a pleasure to introduce the panel members very briefly. So beginning with Professor Rifat Atun, he's Professor of Global Health Systems at Harvard. Before that, and for many years, he was Professor of Healthcare Management here at Imperial College Business School, where he's still deeply involved in research. He worked with Global Fund, advises international organizations such as the WHO, World Bank, and many others. Professor Chaz Buntra is Professor of Translational Medicine at Oxford. Before that was Vice President and Head of Biology at GlaxoSmithKline. Professor Buntra advises both governments and industry on discovery of new drugs. Dr. Jeremy Lower is an economist at the WHO in Geneva. He works extensively on the development of mathematical models for cost effectiveness of intervention across the healthcare system, and is working on the very exciting topic of global public goods in health and healthcare. And I think the first question would be precisely to you. So we've seen there are lots of challenges ahead, right? So if you had to single out one specific challenge do you think is the most important over the next 20 years or so? Which would that be?
Well, first of all, the one challenge I would note has several parts. And I think it depends on where you're sitting. I was very, very interested to hear Mark Britnell's talk because I think the vision that it expresses is one that we share at WHO, but we've been coming to that position rather lately. So I think that one of the challenges is for the kind of the public sector driven and focused organizations. And they may be in government, in a domestic setting, or they may be in international organizations. One of the primary challenges for the next 15 years is for us really to understand that there's a lot more out there in healthcare than, that we're looking, so to speak, at the tip of the iceberg. And we're addressing our policy messages just to the tip of the iceberg. And so we're really missing where a lot of the action is. And that has a certain amount of logic behind it. These organizations and a lot of the public sector approach to healthcare is really a post-Second World War phenomenon where there was a very strong case for strong public action in the social sector. And so we have about, in OECD countries, about 70% public financing in healthcare. Whereas in non-OECD countries, it's about the inverse. It's about 30% public and 70% private. So given that our focus is really more in WHO, and I would say in that public sector international organization context, it's really on those other countries. I think we have to learn how to shift our messages to really address the entire iceberg and not just the part that we can see or the part that we can focus on, and where our privileged stakeholders, where we have very good relationships with them. We have to broaden our focus. And I think from the other side, and this is the second aspect of the challenge that I see, is really when you look at it from, not necessarily from the public sector standpoint, but when you look at it from a holistic standpoint. I think over the last 15 years, one of the tremendous shifts that has occurred is that billions of dollars of internationally funded public money largely has gone into healthcare in developing countries. And that has radically changed the game in many of these countries. And we're talking about an amount that is, on the order of, let's say, $50 billion over 15 years. And that has meant in many of these countries that finance is no longer the binding constraint, that we're running up against other constraints. So looking back now from where we sit, I think the challenge for you, for the business community, so to speak, is really when you consider that a lot of that finance has gone into funding commodities and supplies, that what has been lost has been those core capacities of the health system that are public goods, both on the national level, public goods in the sense that the market is not going to provide them, therefore the public sector has a duty to provide them. But then on the international level, there's a different set of public goods that have been lost in this tremendous, flow of funding into health. And those are things, the more governance-related aspect of public goods. And you could call that sort of the Ebola gap. What happened that allowed this relatively difficultly transmitted disease to take off and become a global threat was weak health systems. And so I think for the business community, there's a fundamentally limiting factor that you face that is, how do we work around health systems that have essentially been starved of some of their core capacities in favor of funding verticalized, commodity-driven systems? So I think depending on where you're looking, the challenges are different. For us, the challenge is very much to understand the larger health economy, the role of the private sector, and to incorporate that in our policy. And I think for the business world, it's really how can we work through, because a lot of the growing global demand is going to be in these countries, how can we work through systems that are fundamentally weak and impoverished in certain of their core capacities? Thank you.
And that's just the tip of the iceberg. Rivan, since this is just the tip of the iceberg and so many challenges, how do you see the role of innovation in supporting our health systems to be able to tackle them?
Well, there are many challenges, but of course there are many opportunities. I think this is what's so exciting. But I can only agree with Jeremy, being a professor of global health systems, that we have to focus on health systems. But why do we need to focus on health systems in providing the solutions that to the problems that Mark has identified? So if you take a step back and look at innovation, actually innovation, we use innovation very loosely. I think it's one of the most used and abused words. And it's an area I'm very genuinely interested in. And we have colleagues such as David Gann here who spent their lives on innovation. We really need to break it down. What type of innovation and where? In health systems, we have a challenge of a mismatch between excellent innovation that's happening in medical devices, in health informatics, in pharmaceuticals. And that is very dynamic, especially I think in the medical device sector and the transition in the pharmaceutical industry is going through. The problem is actually the part called health systems. I'll tell you an anecdote. I trained in England as a physician, and I did my postgraduate training at a hospital. That's in London. That went back to, I think, 13th century. And one of my professors always proudly used to say to me, "This room goes back to 13th century." And I used to look at him and say, well, nothing has changed since then. So the problem is that the part that needs to change has not changed. Medical devices account for 5% of health expenditures in OECD countries. Pharmaceuticals, another 12 to 15%. So collectively, 20%. The vast majority of expenditures in the delivery part, 80%. There, innovation has been lacking. Many health systems are still on a trajectory that began 100, 150, 200 years ago, even going back to the hospital I worked in. And nothing much had changed, actually, since the 13th century in terms of practice, unfortunately. So there's a mismatch between delivery of innovation in terms of new products, new solutions, and innovation in delivery. We've not innovated in delivery. Call it business model, call it whatever you like. But we have examples of what I call boutique examples of interesting innovations. But we have the same case that is being turned over, repeated. We need innovation at health system level that changes organizational design, that changes financing, that changes provider payment systems with appropriate incentives, that changes resource allocation mechanisms, that also changes the resources that we provide, including human resources. But all of this needs to happen at the same time. Changing just a provider payment system is not going to change the system. We learned from post-Soviet context. So I had an opportunity to work in many of the post-Soviet countries, I think almost all with the exception of Belarus and Turkmenistan. There, they introduced financing reform. So they didn't change the content. What happened? Not much change, with the exception of, say, Estonia, that was able to transform the system as a whole. So we need to take a step back and say, what kind of innovation is needed? The innovation must focus on delivering solutions to improve outcomes consistently. I don't think this can be done by having another global institution. Those of us who've worked in Geneva will tell you that I think global institutions have an important role in setting norms and standards, but they tend to converge towards averages, and they take a long time to do things. What's needed is actually developing networks of innovators and providing an ecosystem that enables a scale-up of innovations. That brings together the excellence in innovation in technology with excellence in innovation in delivery. It's the latter part that is missing. Mm-hmm. Now, how might this happen? I think we have a lot to learn from the business sector, because business sectors, or business in general, they're very agile. They respond to market signals. They're able to change focus. They're able to think creatively. They're not, but that needs in any country an enabling environment for innovations to come through. We need to create an environment where public and private sector can work together. In fact, this notion of public versus private, I think it's redundant. What matters is for a country to be able to use the available assets in the most optimal way. I think we should get rid of this binary, really artificial construct of public versus private. These are assets of the country. If an organization or institution can provide an innovation and solution to achieve outcomes, then so be it. So the focus shouldn't be on inputs. Focus should be on improving outcomes, creating value, but also creating an enabling environment where innovation, not just in technology, can thrive, but innovation in the delivery models can actually thrive, but can be scaled up and replicated.
That's a great point, and which also begs a number of questions, right? So if there is probably an area where people think about when they say innovation, is the pharmaceutical industry. That's a question for Chad, because you've been quite critical about waste and duplication of effort in the development of new drugs. So do you think the industry can reinvent itself in order to help us to tackle all these challenges and still avoid this type of problems?
Thank you, Pedro. I mean, so what I'll do is I'll just, in the next few minutes, just say a few words about duplication, link it up with risk, and we've heard about that this morning, and just maybe a few words about solution. So Pedro's right. One of the things I worry about is that in biomedical research, and this is not just in industry, it's in academia as well, there is massive duplication. There are many, many groups who work on the same few ideas, the same few targets in parallel, in secret. And they spend 5, 6, 7 years coming up with a proprietary molecule, and then they test it in the clinic, and we know the failure rate in the clinic is 7 out of 10, 8 out of 10, 9 out of 10. Most of our novel ideas, when we take them into the clinic, they fail. Now, of course, you know, if one company fails, it's likely the other 19 companies working on the same thing, they will also fail. Now, aggregate, that is an incredible waste of money. It's an incredible waste of people's careers, but it's actually a tragic waste of patience. Frankly, the way we're doing drug discovery today, early discovery, we are exposing patients to molecules that other groups already know are destined for failure. So that's something I worry about. I'm interested, obviously, in generating new medicines, and I'm interested in early discovery. And so let me just say a few words about risk. Now, of course, we all want medicines that are more efficacious and safer. We all want to realize the dream of precision medicine. So the right medicine to the right patient at the right time, at the right dose, etc. This is all very challenging. What we call target discovery, so actually coming up with a new idea and pushing that forward in a particular disease area, that is something, frankly, we are not good at. Academia is not good, biotech's not good, and pharma's not good. And by target discovery, I mean just simplistically, in each of us, let's say there's 20,000 different proteins. Any one of those proteins could be a drug target. In the clinic, we've got hundreds of chronic diseases. Many of those are probably 10 different diseases, and we've got 7,000 rare diseases. And our ability today to say that this novel protein, if I modulate it, if I inhibit it, it's going to work in this subset of patients is appalling. This is why when we take these ideas into the clinic, 8, 9 out of 10, we fail. Because our understanding of human disease is poor. We don't really have a clue what causes schizophrenia or depression at the molecular level. We don't have good biomarkers for many of these diseases. I can't say to a depressed patient, are you less depressed today than you were last week? A lot of the animal models that we use to predict clinical utility, frankly, I think are largely a waste of time. And there are some drugs out there, we don't even know how they work. So how can you design better ones if you don't know how the existing one works? And this whole system is becoming actually more complex. Now we're recognizing environment has a massive effect on the initiation, the development, and maintenance of chronic disease. And by environment, I mean diet, exercise, early life experiences, pollution, stress, etc. These have a massive effect on probably most, if not all, chronic diseases, etc. We're also recognizing the microbiome, these bugs in the gut. They have a massive effect on drug uptake and patient heterogeneity, etc. And we're just starting to understand the role of some of these things. So that sounds a bit depressing. So what's the solution? I mean, you're right. It's an opportunity now. I think the solution is, frankly, we have to, in this early space, we have to pool our resources. We pool our infrastructure, pool our expertise. If we do that, we have a better probability of success. I think we need to share wherever we can. Let's reduce this secrecy. Let's reduce this competition in early discovery. Because frankly, if we don't, we will not have a new drug for Alzheimer's in 10, 15, 20 years' time, etc. And of course, that's one disease area that's practically going to cripple some NHS systems. So, thank you.
Well, that's very good. And I mean, I was thinking about problems with the discovery of new drugs, problems with health systems. I mean, we don't want to finish with a negative note. So, in the challenge to the panel, I mean, good examples. Which countries are getting things
I think
right?
on the contrary, I think there's an incredible opportunity because so little has been done. Mark mentioned some figures in relation to inefficiency with work done with my colleague in my department, actually, David Bloom. IMF estimates, as well as WHO and OECD, that 30 to 50% of health system expenditures are wasted. Now, we're not talking about rounding errors here. These are very big sums, 30 to 50%. In the US, the waste estimated by colleagues at Harvard is $1 trillion a year. So opportunity is great. Opportunity for innovation is incredible because so little has been done. I think the challenge is we've focused too much on more of the same inputs. We need to completely rethink what are we going to invest in. We have to invest in outcomes. Now, let the organizations, whether they're public, whether they're non-profit distributing, whether they're state-owned, it doesn't really matter. Let them work together, let them innovate, but learn from this and enable scale-up. So the politicians have to, or the funders, and I was a funder at the Global Fund. We were providing funding to 160 countries each year. Actually, not having money was a big problem, but actually having money was an even bigger problem because you have to invest in the right areas. And we were searching for these innovations. There are really good examples from pockets of innovations. I mean, if looking at countries, and we've seen from Mark a number of examples, there are innovations happening, good innovations in the Nordic countries where there are sort of integrated delivery models that are emerging. There are pockets of excellence in the US where we are seeing technology-enabled delivery models. I mentioned Turkey. Singapore does very interesting work. But I think the Canadian system is functional in terms of organization delivery models. The Brazilian system is good. So there are examples. But again, much of the focus has been on delivering inputs using the same kind of ingredients. We have to take a step back and say, let's focus on funding outcomes. Let's take some risk and enable the organizations to come up with new models. Remove the constraints on medical professional or other health professionals, what they can and they cannot do, and then enable innovative models to emerge. This is a long journey. Problems are not going away, nor health systems. So the sooner we start, the better.
If I could make
Absolutely.
a brief observation, it seems to me that, Chaz, you point to a classic example of a cooperation failure. And to exaggerate somewhat, I mean, and going back also to Mark's talk, I think every solution that has been innovated in healthcare has been an attempt to solve a cooperation failure. And every failure in healthcare to deliver the kind of outcomes that we want at the right price and with the best value for money is because of a cooperation failure. So this issue of political science looks at this, economics looks at this, business and management looks at this. We have to somehow pool that knowledge about what are best practices in addressing different kinds of coordination problems and those, really solving those cooperation failures. Because in health, they're pervasive. They go down to the fact that, you can never be really your own doctor, So you have to outsource that capacity to somebody who is acting as your agent. And so it's fundamental in health, this idea of a principal-agent problem or cooperation failure. And I think we really need to just address a lot more concentrated thinking and pool our resources from across a range of disciplines to understand how those can be addressed.
So could I follow on from that? I mean, I'm actually very optimistic about the UK. I think in the UK we've got great universities churning out talent, innovators, entrepreneurs, leaders. I think in the UK, many of our funding leaders have had the vision to invest in large-scale infrastructures and resources and databases, with hundreds of thousands of patients. And I'm thinking in terms of, the Genome England project, the UK Biobank, the Sanger Centre, and indeed the NHS. That is a massive opportunity for us. I also think in terms of starting, say, for example, new companies, et cetera, in the UK, per head, we have more investment income than any other country in Europe. Accepted, it's not as much as the US, but we have more than other countries in Europe. I also think in the UK, we have a culture of what we call open innovation or collaboration or bringing together lots of disciplines, et cetera, et cetera. And frankly, over the past decade, that has been championed by organizations like the Wellcome Trust. It's also been championed by the Innovative Medicines Initiative across Europe. And I have to say, GSK was a leader in this, I think, 10 years ago. That sort of culture of collaboration, open innovation, does not exist in the US. So I am very optimistic about the UK.
Mm-hmm. So maybe a comment on both of your both of the points that you raised. I think one of the challenges in health systems, why we don't achieve good coordination, is because we are dealing with archaic structures. So you're trying to fit a round peg through a square hole, or the other way around. If you look at universities, hospitals, WHO, they're oriented around diseases. The issues around an individual that has multiple factors, as Chas said, not just risk factors in relation to health, but multiple upstream social determinants. So trying to get these vertical organizational structures to talk to each other, any of you who spend time in health systems will tell you, is very, very, very difficult. So unless we shift our thinking from focusing on an individual disease or an individual group to actually the care delivery process with outcome in mind, that coordination is not going to happen because you're trying to bring together in a horizontal way multiple and very sclerotic, rigid structures. And there are countries that are designed, that have health systems that are designed from early stage prevention to very complex interventions around a disease. So that's a very big challenge. So that's first. Secondly, I think we worry too much about so-called failure. By definition, innovation requires some kind of risk-taking. So we should tolerate. Maybe not everything is going to be as successful as each other, but I think we need to relax the constraints and think, let's introduce new models and learn from them. So next time this can be done better. So one can improve iteratively. And I think the purchasers or funders need to enable this to happen. The third issue is we try and impose simplistic structures on very complex systems. Health systems by nature are complex. There are many moving parts at many levels. We try and impose centrally planned, simple structures or coordinating mechanisms on very, very complex systems, rather than thinking about how can we allow locality to come up with an optimal solution that is suitable for that context, rather than thinking about imposing a solution made in Washington or Geneva or elsewhere. So I think these are the three issues that we need to think about.
So we have challenges, but we also have solutions, and we have good examples, good practice. So questions from the audience? Yes, please.
So, Nick Peters, Professor of Cardiology at Imperial College and Imperial College NHS Trust. And I'd just like to make some points that reinforce the points that Professor Atun made, with which I absolutely agree. And I'll do so with an illustration. So last week I was awarded some funds to establish a Connected Care Bureau at Imperial College Healthcare NHS Trust, a kind of combined activity. And I did so on the basis of a very simple clinical pathway that for me was a no-brainer because it made a health economic case hands down. Very simple pathway, and I thought, this will do it. And then I started talking to the Director of Strategy at Imperial College NHS Trust, and she said to me, yeah, the problem is that if this saves the local health economy money, the problem is that somebody is going to lose out, that somebody's budget is going to be adversely affected. And this speaks to the point that Professor Atun made about archaic structures and the complexity. So here am I, on the demand side, coming up with a demand-led solution, which also speaks to a point you made. And I think it's extraordinary how little healthcare providers, actually at the coalface, are represented here today. I think it's really interesting, given that we need to focus more on the demand side pull than the supply side push, which is another point you've made. But it was extraordinary to me that if something was going to save the local health economy money and save lives, and I don't need to go into the detail of what that pathway was, but it was absolutely clear that that's what it was going to do, that the problem was overcoming the local health economy because of people's budgets being adversely affected, and the hoops we had to jump through in order to get this initiative off the ground. And we can now establish the Connected Care Bureau, which is highly innovative, I could write a book about. In fact, given Mark's ability to promote, maybe I should write it with him.
Can I just follow on from that? I mean, I think one of the challenges we have, and you know, we all moan about there isn't enough funding. I'm not convinced we're going to get more R&D funding globally, but that funding is constrained. What I worry about is that we as academics, we maybe as entrepreneurs, we as institutes, we're competing with each other for the same small pot of money. I think the problems we're trying to address are so big, no one group, no one company, no one university is going to do this on their own. And the only way we're going to do it is by coming together and presenting some of these big goals. So the example I would give, the NIH, you know, they currently have spend 30 billion, etc. The problem is people working in prostate cancer go to them, oh, we need more money. Alzheimer's, we need more money. Antimicrobial resistance, we need more money. And everybody's just competing with each other. In the UK...
The point I'd make is that that's all about the supply side push.
Yes,
that's
absolutely.
The 20%.
Yes.
It's about the 80%.
Yes.
It's about the delivery.
Yes.
We need to make care better and more cost effective, not for the many, not more expensive for the few. And so we need to focus on the 80%. Now, am I right in thinking that the 80%
absolutely,
is about the delivery?
absolutely, Nick.
That's a very
Yes.
large sum of money.
Yes.
And if we can just get the demand side articulated properly and express to the supply side what needs to be done, then we've changed the whole paradigm. And I'm not hearing enough paradigm shift today with respect to the business and economics that are represented here. Maybe I am in a minority on the healthcare delivery side, and maybe deliverers like me are considered more of the problem than they are part of the solution. But I need to be the audience for what I'm here today, but what we need to hear is more about a paradigm shift to demand-side pull and articulation and better delivery with that 80%.
That's a great point. Oh, we have a second question here, and you can address them all.
Chaos and EPFL. I really share completely the idea of this cooperation, collaboration, sharing, and particularly because I'm a basic scientist in what Chas mentioned about early stages for innovation. But there is, I'd like to find solutions, but there are some problems, and they're not easy to solve. You mentioned one, going for the same pot of money. The other one is, and it seems very simple, but it's actually very complicated. It's intellectual property from the side of industry. If it's something generic, providing access to data, to gene banks and so on, that's generic enough. There is one can easily put data together. But when one starts to work to develop a drug, there is this problem. And even within academia, I was involved in an interesting experiment. A private sector, actually funding for a kind of Manhattan project to study the type of cells I study in the brain, which are the glial cells, the non-neuronal cells, the other half of the brain, to try to see whether this could be an interesting target for developing drugs. And this private foundation put together a number of leaders, let's call them like this, in the field to come up with innovative approaches, sharing data, sharing postdocs, and all that. Well, scientists, interestingly enough, it worked more or less, but their universities came into play and started putting hurdles and issues about technology transfer, IP, and eventually this private funding said, well, we don't want to spend the money for lawyers, we like to spend it for science, and that's where it stopped.
Absolutely. So there's a third question. I suggest that the panel then addresses them all, because we're sort of pressed with time. Carol.
Hi, I'm Carol Proper, Professor of Economics here at the Business School. I think what the three of you are talking about is governance, that you need good governance to make systems work. I think the examples you gave, Rifat, in the main, the good governance you're talking about is associated with strong governments. Erdogan, Singapore, the Nordic countries, to some extent Israel. But I don't think governance has to be provided. Well, my question to you as a panel is, who do you think should be providing the governance to get the outcomes and overcome the challenges that you've all talked about?
Yes.
Well,
There was a final question in the back.
Yeah.
Okay, it's Melanie Lee. I'm the Chief Scientific Officer for BTG. We're in the world of interventional medicine, and to the discussion about making sure that you have the delivery side demand. We specialise in interventional medicine. We work with interventional radiologists and oncology specialists. So our products are products, but they're also procedures that we have to teach to the world of medicine. We cannot find a marketplace without our customers telling us how to find it. We cannot get referral pathways changed without the customers telling us what we have to do it. So this business that I'm now in, having been in Glaxo and biotech and on many other types of medicine, this business is now absolutely forcing a change. There's no commercialization unless you understand how the customers are going to use your product. It's a complete paradigm change, and it's why I joined BTG.
So 3 minutes to address three great questions.
3 minutes.
So if
Three questions, 3 minutes.
If I could.
3 minutes each or 1 minute each?
1 minute question.
1 minute.
I'm just going to go right to my area of interest, which is the governance question. I actually tend to disagree with this dichotomy between supply and demand. I'm not going to address that. But I think the thing about governance is that we all have our different words for it. We call it, there are coordination problems, governance. For me, governance is the entirety of the incentives, the norms, the standards, the rules that determine behaviors of all the actors in the system. Governance, in a holistic sense, is very, very decentralized in healthcare. So that, is a problem that, you know, putting a label on it of governance is not going to fix. We could talk about it in terms of coordination, and we could talk about it in terms of public goods. We have to understand where are the solutions to incentives that work and adopt those. I mean, I would agree, to come back to your question, and also this would be my last remark, on the success stories. I would tend to agree with Mark or Rifat that there are isolated successes in particular areas that are you know, sentinel events that we should be quite cognizant of and adapt and learn from. But there's nowhere that really gets the entire picture right. So I like very much the focus on governance, but I think at the end of the day, that's really just another word that we use to describe this very decentralized set of incentives that is acting in the health system. That starts from the individual all the way up through government, international organizations, you know, national health, your local health authorities. All of these are governance structures.
Very good. Two other questions. Quick comments on.
I'll go back to Pierre's comment. So I work in a very competitive university. But what we've been doing is we've said we're going to work on completely novel areas of biology to come up with completely novel drug targets. We've generated high-quality starting points for drug discovery. We share all of those with the world immediately. Even before we published on them, we are working with several large pharma companies. We're getting funded by several large pharma companies. We've got many examples where we've accelerated science, accelerated drug discovery, and accelerated the creation of new companies. The governance of all of this involves all the public funders, the Wellcome Trust. It involves all the pharma funders and patient groups.
Yes. So excellent question. I can only agree with Carol, of course. Governance issue is very important. Governance at the national level, but also at local level. And we published a paper in Health Affairs in January, looking at effect of governance on health outcomes. In Brazil, that is about 5,000 municipalities. So there's enough variation for us to be able to do a nice econometric model. And what we are able to show is that amenable mortality declined when family health strategy was introduced, which is an innovation. But in the presence of good governance, and we constructed a governance index, outcomes were almost 9-fold difference compared to worse. So governance is critically important, national level, but also local level. Professor Peters is left. What he's trying to do is something very novel and highly innovative. He's trying to turn things around, literally. Focus on pathways that focus on the care process. But he has these vertical structures that are getting in the way. Vertical structures in terms of organizational structures, but also the budgets. So I think that's the kind of innovation we should invest in. But ensure that they go beyond what I call boutique examples. So we need to create the ecosystems that enable us to replicate and scale up these innovations. We don't need more boutique examples. There are plenty of these cases. We need innovation at scale.
Perfect. So we're really pressed with time, and since we're going to discuss this in the second session as well, I'll just thank the speakers.
Thank you.
Well done.
We don't have a break right now, right?
No.
The break is after the next one.
Thank you. Settle down.
Sorry. The microphone is not working. Sorry. Now it's working. Sorry. So let me introduce Professor Pierre Magistretti, please. I'm delighted to introduce him. He already has done some of my job by introducing himself briefly. I'm glad he did that because his list of achievement and contribution to science and innovation is way too long for me to summarize it right now.
So let me just tell you just a few things about Pierre. Pierre is very involved, of course, he's a leading expert in neuroscience, and as well as doing a lot of research, he also wears many hats. And let me just give you a few, and then leave you the floor. Pierre is the Dean of the Division of Biological and Environmental Sciences and Engineering at Chaos University in Saudi Arabia. He also has an affiliation as Professor of Neuroscience at the Brain Mind Institute at the EPFL. He's the President of the International Brain Research Organization, and much more. So Pierre, what you have to say is much more important than me trying to make a comprehensive list, so it's all yours.
Thank you, Laura. Thank you, James, for the invitation. I really enjoy being here in a group that I usually don't. First of all, I understand it's quite unique to have people from different horizons like here, and usually my talks are to my colleagues, basic scientists, and there are maybe a few, but so it's a very interesting for me. I am, as Laura said, I'm a basic scientist working on particular problems in the brain, in particular trying to understand neurodegeneration, mechanisms of neuronal death. I also have some engagement in administration as dean and being involved in a few organizations. And also as in innovation, I have started 2 companies that in the field of biology. So when I was contacted to give a talk here, I said, well, let me think a little bit about how I view the issue on innovation, in particular in terms of the initial steps of innovation and related to the brain. So mine will be a pretty focused topic, but I think it applies to probably different domains of biomedical research and healthcare. So going to the brain, of course, we have several challenges, and some were already mentioned. In innovation, in the field of neurology and mental health, it's really a major and growing problem, in part, but not exclusively, linked to the aging population. So we have a problem. And it's a problem that has an impact, of course, a human impact, but also a very remarkable economic impact. Somehow, about 30% of the healthcare costs in Europe are related to diseases of the brain. We heard 15% for mental health, but also other neurological disorders. It's a lot of money, 800 billion. And it's, you know, one always indicates mine is more important. I don't know. But certainly it's a problem that involves human cost and economic cost. Now, what are the challenges that we have for this innovation, for this big problem? Well, first of all, the reality is, it's very disappointing, there are not many efficient treatments for several diseases that go at least at the real process. We have drugs that work. Sometimes we don't even know exactly how they work. But certainly there is a lack of an impact in terms of drugs on the diseases as there are in other fields, such as infectious diseases, for example, even though resistance is developing. But still, the field is much better off. We know that there is a rising cost of drug development. That's a general problem. And in terms of neuroscience in general, there is a disinvestment from the pharma company. And as I mentioned, a considerable economic burden. Now, on the other hand, there is a lot of research. Some of it, I agree fully with Jas, again, a lot of duplications. So often, unfortunately, on topics that go nowhere, and I will be a bit critical, but I think, for example, the beta-amyloid hypothesis in Alzheimer's disease is a very bad example. But anyway, you have thousands and thousands of papers every year published in the best journals, and the actual impact of these publications, funded by public funding, with the best minds in the field, the impact is low. This is very disappointing. Another aspect which is different in neuro is that actually the shares of new molecular entities is relatively low. I mean, it goes back to the idea of treatments that are not efficient. So this is a reality. Why it is so, it's not clear. But clearly, in infectious diseases, oncology, metabolism, cardiology, a lot of molecular entities have been produced over the last few decades, and this is not the case in neurology. But on the other hand, there are some interesting features about potential for innovation, in addition, obviously, to the hopefully classical pharma development that are typical for neuroscience. Well, there are, for example, the interface between electrical activity of the brain and with electrical engineering. I mean, as we will see, the brain-machine interfaces, these are devices that actually may have an impact, and I will give you an example. In psychiatry, for example, there is a potential for virtual reality tools, but also in other aspects. So this is something that may provide new resources for innovation. There are techniques for imaging. There are new techniques to absolutely stimulate specifically brain cells. This is working in animals for the time being, hopefully maybe one day in humans. We have viral vectors we can try, even though it's very challenging, gene therapy, particularly, for example, in the retina. Well, the omics, of course, and also something interesting, particularly for prevention, that may be general, but certainly interesting for the brain, is nutrition. So let me give you an example of a really resounding success in therapy in neuroscience. It didn't come from molecules. It came from neurosurgery, in particular by the pioneer, Alim Louis Benabid. He developed the technique of deep brain stimulation, which has been applied very successfully to control the symptoms of Parkinson's disease. Now it's being used also in obsessive compulsive disorders. In a few other applications, it's not the panacea, but in movement disorders, certainly it's something absolutely remarkable. It's being even tried in psychiatry with varied successes. So this is something, it's a real innovation, came from a clinician in the operating room that has a major impact. It's probably the greatest innovation in neuroscience, in neurology, and it came from something that is technology driven and clinical observation. I mentioned the divestment of a lot of companies from neuroscience for other topics, and this is fully understandable. But then there is a need for creating an ecosystem that would somehow obviate the problems that I mentioned. And this is really, it's a slide actually developed by the past president of EPFL, Patrick Abisher, with whom we shared many ideas concerning this, what we call neurotranslation, how to go from very good basic research in neuroscience, and there is a lot in the world, to something that eventually ends up in creating value, and value in all the senses, including and mainly cure patients. So would be important, and maybe that's what you are having, maybe, Chas, in Oxford. You're very lucky. I am very envious. But academic multidisciplinary labs that share data, that share resources, that have access to clinicians at early stages. This is very important. We need probably accelerators from non-profit side, foundations, patients associations, national funding agencies in some countries, I mean, that not only fund basic research, but also the translation from the bench to a first step in terms of company. And then, of course, it's important, it's useful to have this startup incubation. This is pretty clear. And then we need cooperation. I mean, we all agree on that. That can come at any stage, but certainly it's something absolutely vital. And then you need funds, and they obviously can come from the private sector, from VCs, for example. So let me give you two quick examples from the two universities I've been involved and a well-established one, where I'm still professor there. I've been there for 20 years at EPFL, which has been extremely successful over the last 15 years in terms of developing these translational approaches. and creation of companies. And KAUST, King Abdullah University of Science and Technology, which is a very new university, started in 2009. It's an international, it's also very much is trying to set into place from the very beginning a strong translational capacity that goes hand in hand with the basic research. It's a very interesting experiment. By the way, the president of Imperial, as you know, or may know, is actually on the board of KAUST, so I happen to see her once in a while. EPFL has been, as I said, a great success. Look at 1999, 2000, actually coincides with the presidency of Patrick Abisher, really a visionary in this field, and look at the incredible growth of startup. And last year, Abisher is very proud to say that EPFL had more VC funds than the whole state of New York. And that's pretty amazing. And one of the way this works, again, it's probably very easy to think of, but it's maybe more difficult to implement. Of course, having a strong research campus with an innovation park next to it and just go around and with cross-fertilization and with some funds for proof of concept and then moving ahead. But it's not easy. Even in Switzerland, the first few steps actually are, there is really a positive ecosystem in Switzerland from even the government, from the universities, from some business angels. But then going from the 2-3 million to the next step is actually something that is lacking there. KAUST, let me say a few words because maybe you're less familiar about KAUST. KAUST, as I said, it's located in Jeddah, north of Jeddah, 60 kilometers north of Jeddah, on the shores of the Red Sea. And it's really a city in itself. There is an academic campus, there is a town center, huge community, 7,000 people live there. But, and for the purpose of today's discussion, there is a large area devoted to research and technology park and an innovation cluster with funding for the proof of concept, but even a venture fund that is actually funded in large part by the university to go a bit further on the next step. Well, these are just data. It's a small university, about 150 faculty. The idea is to go up to 220, so the same size as Caltech. Well, you know, one can use whatever index one likes, but this is a nice one. Actually, KAUST in a few years has become #1 in terms of citations per faculty. So it means that what the faculty produces is read and cited. And then essentially 3 divisions, very technology-driven, biological and environmental sciences, computer, electrical and mathematical science, and physical sciences. Now, let me go to the important part for this discussion today. First, the center is this innovation and economic development with a number of elements that are an integral part not only of a special unit of KAUST, but they're really part of KAUST. I mean, I think what is very attractive is that it started with this ambition to have a capacity for translation. And I'll give you, because we're talking about healthcare and innovation, a view about bioinnovation. There is a very important need locally in the kingdom for developing capacities to diagnostics, biomedical research and development, training, and also clinical trials. It's really a field that needs a lot of transformation. And one of the views at KAUST is to actually create that KAUST becomes an innovation hub whereby it can attract international entities, pharma, biotechs, and then link with the rest of the country, which needs it. So in a way, it would be a win-win-win situation. And there is, the most important thing, there is support at all levels for this kind of transition. And one example, given the important issue about genetic disorders in the kingdom, is, for example, to establish, and is being established, a genomic diagnostic platforms that really creates a virtuous cycle between diagnostic, a service, but also innovation and exchanges with academia and industry. So to conclude, we have some points for reflection. So brain aging and mental health represent major human and economic challenges. That's an obvious statement, but it's a real one. Despite remarkable progress, this is a bit frustrating, in understanding brain function, there is still considerable knowledge to be acquired about brain function for the development of new therapies. Alarmingly, I think this is has to be noted, the big pharma have disinvested from neuroscience research. Possibly Alzheimer's disease is still an interesting topic for the industry. And then what do we need? I mean, this is the list, and how they play out, it's something to be seen. But certainly, sustained government support is still very important, no matter its limitations that are real, but it's very important to generate investigator-driven projects and possibly new ideas. Well, it's a kind of a generic statement. There is a need for different ways to develop more this private-public partnership and private and new models for collaborations. And I just showed you one that's being developed at EPFL under the leadership of Patrick Hebischer. And so this is actually something that we need a new translational research model, and I'm very curious to talk more with Chess to see how they do it in Oxford. Thank you.
Maybe a couple of questions.
Yeah. Yeah, that was superb. Thank you. I mean, I think we heard earlier the comment that in this game we need to embrace risk. And this is one of the things I admire about the US. I think some of the entrepreneurs there are much more receptive to risk, and the investors. Yes. But I think the other thing that's quite nice in the US is that people work at Harvard, and then they'll go off and set up a biotech, and then they'll go and work in Novartis, and then go back to MIT. And I think that is brilliant.
Yes.
And I mean, we've got Melanie Lee here, and she's done that, worked in academia, big pharma, biotech, etc. I think we need more people like that. We need to break down these barriers. Yes. That's the only way we're going to do it.
I couldn't agree more. Absolutely. You are an example, in fact.
Maybe one just very last question. Is this on track? No? So shall I invite you to the break then? Thank you very much. Thank you, Pierre.
Thanks for that. That's very interesting. And, I think it's very good to get the fact that mental and brain issues are, they're kind of neglected in these discussions a lot, I think.
Yes,
and,
yes. I think it's, of course, it's easier for me because I'm right there.
No, but it was nice to see how we're supposed to carry out research from.
And this sort of theme of ecosystems is beginning to come through, and new business models.
And it actually can apply probably to other diseases.
Yeah, yeah. Right, good.
I will try to catch our joining speaker.
So who we've got? Mark. I've seen some of them.
Yeah.
He's got one in the mic still.
Oh, I think he went up to the alumni place to meet some students. So he's up there, I think. Yeah. Okay, please take your seats.
Yes. Cyril, the Smith and
Cyril,
Nephew.
good to meet you. Very good. Right.
Nice to meet you.
Hello, good to see you. Right. I'm not chairing this. Marissa is. Yes. Yeah. Yes.
What do you want to say?
Mark?
Yes.
You mic'd up? Or no, not yet? Right, okay. I'll just introduce you, and then you do them, okay, yeah. Okay, let's get started again, please. Okay, settle down, everybody. Right, now. Okay, we're moving on now from the challenges. We've heard about the big issues that need to be dealt with, and we've teased out that a lot of it is actually about the archaic sort of delivery side. And on one side, you've got fantastically dynamic med tech and pharma and other areas of technology development in healthcare, but then you've got this archaic delivery side. So we're beginning to get some themes going here. But now is the time when we start digging down a bit deeper into some of the detail. And but very pleased to have Marissa Moraldo here, who's associate professor in the business school, working in health economics. And Marissa's going to be chairing this panel with a range of people who will be introduced in a moment from a variety of different sides of the healthcare technology innovation sector. So, Marissa, over to you.
Thank you, James, very much. So, the objective so we have spoken about challenges in innovation. The objective of this panel is really to put those challenges into the context of pharma, medical devices, and biotech industry. So we have a very diverse panel. I'm really pleased to be chairing this discussion. And we are going to learn about the challenges they face, the mitigating strategies they're implementing to address those challenges, but also what are the key must-dos, in their opinion, that need to be in place so that we can ensure in the future a sustainable stream of innovation in key areas of need. So I'm very distinguished. We have a very distinguished panel of speakers. I would like to very briefly introduce them before we kick off with the discussion. So they change their, they are in different order. So
disruption.
So anyway, so the first disruptive innovation. That's just to test my attention. So I'd first like to welcome Mark Hicken, that is Managing Director of UK Ireland at Janssen. Throughout his 19-year career with Janssen, Mark has shown consistent commitment to patients across a number of therapeutic areas from HIV to oncology, where he has worked in a number of new business units. Mark is from the UK, yet has global experiences of the pharmaceutical industry, both at an operational and strategic level. Mark is the great believer that the pharmaceutical industry leader of today has to grow their business, develop talent, and fully engage with the external environment, be it patients, governments, clinicians, policymakers, HTA bodies, or regulators. We have our next speaker, that is Ted Garway Heath, and is an International Glaucoma Association Professor of Ophthalmology for Glaucoma and Allied Studies at University College of London, and the theme leader for Vision Assessment and Imaging at the National Institute for Health Research Biomedical Research Center that is based at the Moorfields High Hospital and UCL Institute of Ophthalmology. TED has bestowed the prestigious Alcon Research Institute Award for outstanding contributions to ophthalmic research, as well as the World Glaucoma Association Research Recognition Award, and he was also cited as one of the 100 most influential people in ophthalmology worldwide. Our next speaker is Kai Stober, and Kai is the Vice President of Global Innovation and Shionogi Europe. He received his MSc in Biological Sciences from the University of Bonn and a PhD from University of Cambridge. In his current role, he works with senior executives in Osaka, Japan, to define and deliver Shionogi's global innovation strategy. And his focus lies on broadening external networks towards integrated research collaborations across core therapeutic areas with key stakeholders in the innovation ecosystem. He identifies and evaluates horizon technologies and new targets or molecules from external sources, develops technology roadmaps, and engages in clinical liaison for drug development programs. Our next speaker is Eva Lotte Allen, that is Chief Business Officer at Immunocore since May 2013. She has over 25 years of business development experience from the biotechnology and life science industry in both the private and public companies, and is an elected member of the Bioindustry Association Board of the Directors. She also on the board of Targovax. In the past, Eva Lotte worked at Ablings, where she served as Chief Business Officer from 2006, and prior to that, she has served as Senior Director of Business Development and Site Operations at Vertex Pharmaceuticals, and held senior positions also at Oxford, Symmetry International, and Oxford Glycosystems, and she's received a degree in microbiology from the University of Stockholm. And last but not least, Cyril Petit, that is Chief Corporate Officer and President of Global Business Services and Smith & Nephew. And Cyril's current responsibility as an Executive Officer are Corporate Development and Global Business Services. He has completed more than 30 investments in medical and healthcare technologies for Smith & Nephew since 2012. And prior to this, he spent 15 years at General Electric and held progressively senior roles in technology, healthcare, and capital. Cyril has also worked at Goldman Sachs in the past. So thank you very much. You're very welcome. I will first then kick off with a question to Mark. And Mark, Janssen is well known for developing an open innovation approach and also for engaging very closely with users and social enterprises. And my question to you is, do you see this model increasingly replacing the traditional closed approaches to innovation in the pharmaceutical industry?
That's a very difficult question to answer. I think we'll only know in the future whether that's been the case. I think certainly they're going to have to run in parallel. You know, what we believe, and we're not exclusive in that, is that innovation seldom takes place at the core of the business. So what's going to be right for tomorrow is not what we're focused on doing today normally. And innovations, the best innovations often come from closest to the customer or from closest to the problem. That, together with the sort of belief in you know, if you're going to deliver sustainable healthcare, you're going to have to engage and empower the patients and even people before they become patients. So how do you prevent and avoid disease? Those are the things that have kind of driven us in a direction of open innovation. We have J-Labs, we have innovation centers in 4 destinations, 4 sites in the world. And it's a model that we've talked about already, so I won't labor the open innovation point. A couple of comments just on some of the challenges, and I can only give you a UK perspective on this. So partnering with the NHS, and there's a great benefit of having a single provider system, but it's also a bit of a challenge, and it's a very tightly managed system, and we see 2 behaviours that get in the way. One, which has been referenced this morning, is siloed budgeting. So if I spend money on something here and it delivers a benefit somewhere else, and it doesn't help me, why am I going to do that? And I think the first speaker talked a little bit about that. That's a real challenge for us in bringing new innovation through. Second is the near-term financial constraints. So can I spend money now that's going to save me money or deliver a benefit in 5 years? The answer is usually no, and particularly in the way that we're the situation we're in now. Third thing I think is that there needs to be a relationship of trust between innovators and potentially customers or users of the innovation. That's been a bit of a challenge. Where we can help large cap companies like J&J, and Janssen is the pharmaceutical part of Johnson & Johnson, is that we have the resources to pump prime the system. So to champion innovation, to bring new things through. We've done 3 things that I would just specifically reference as sort of examples. One is that we were one of the first companies to introduce outcomes-based payment schemes for pharmaceuticals, so Velcade response scheme for myeloma products, trying to deal with help the health system manage uncertainty in budget allocation, so underwriting risk, and we do that now in mental health as well. So how do you help avoid hospitalization? What happens if you don't? People that are living with schizophrenia, we underwrite the risk and guarantee the outcome. Second thing we've done is try to empower the patients, and we partnered with a social enterprise in the UK called Patients Know Best, who are who claim to be the world's first provider of patient-owned electronic health records. Set up by a physician who had the experience, suffers with a rare disease himself, and every time he interacted with the NHS, a different part of it, he had to explain what was wrong with him to the new person so that mistakes weren't made. We've tried to partner with that company, so we Pump Prime, we invested in that business and gave them the benefit, the scale of our footprint, engaging with the NHS to try and introduce that business as a way of involving patients and their families in the care choices, decisions, and the care pathway. And then generally, just a bigger example is that, just the point about innovation taking place outside of the core of the business. At J&J, we established Janssen Healthcare Innovation about 6 years ago, gave it a budget and said, go and figure out solutions to some of these problems that we've talked about, away from the core of business, away from the P&L, the usual P&L, and go and experiment and try stuff. And there's been a whole bunch of experiments, which I won't talk about, but that's kind of how we've tried to address some of that. So hopefully that starts things off.
Yeah, thank you very much. I was very interested about this risk sharing that, of course, your company is one of the leaders on that. Do you think that this risk-sharing burden that is excessively on the industry side, not only in terms of development and aftermarket launch, is it a sustainable way of incentivizing innovation for the future, or should we change that paradigm? And if we should, how could we do that?
I guess it is until the shareholders walk away, right? I mean, if we can't deliver commercial success, then people will stop buying life science stock and they'll go and buy Apple and General Motors and goodness knows what else. Then the capital dries up, then we've got a problem. So as long as we're not bridging for too long, and as long as there's true partnership, I think it has to be just a way to help move into new spaces. It's the pump priming that really helps, particularly when you're working with a system which is constrained in its ability to invest now for future years. So I think that is going to be a new way forward.
And do you think that risk-sharing model biases innovation towards certain areas and leaves and address certain key areas of need?
Yeah, I think inevitably areas of higher risk, whether it be larger sort of financial risk, we're pretty good at managing in pharmaceuticals the regulatory risk. The bigger challenge we face is the sort of reimbursement and the cost risk. And the systems, and the UK is a particular example of a system that hasn't kept pace. So rapid reimbursement of new medicines, we don't see the same, rapid approval of medicines, we don't see the rapid reimbursement. So we carry that financial risk for a long period. I don't think that's necessarily sustainable. And that's going to be a challenge for us.
So I'll profit from this discussion to move to Kai in terms of, I'd like to ask you about first, what is Shionogi's perspective of new approaches to innovation, but more importantly, Shionogi is quite active in addressing key areas of need, and one of those is antimicrobial resistance. So can you share with us how you are developing new open partnerships and harnessing big data to tackle the AMR challenge?
Pleasure. I think it's been an excellent discussion so far, and as the day goes along, there's ample opportunity to pick up on some of the earlier points. So what struck me this morning was the major challenges that we are facing, as James very eloquently introduced us to. And I think the other day I came across a quote by an American philosopher called Eric Hoffer, who actually said that in changing times, and we really live in changing times, learners will inherit the earth, while the learned will actually find themselves beautifully equipped to deal with a world that no longer exists. So I think it's a beautiful quote that sort of encapsulated open innovation, as Charles has very eloquently made the case for open innovation, to avoid duplication, poor resources, etc. So open innovation and open science is something that I'm very passionate and Shionogi is very passionate about, and we are a newcomer to the European scene, to the European innovation ecosystem. Now, Charles made a very strong case for open innovation, open science in the UK, painted a very positive picture, something that I would share. But I think still, when we look at public-private partnerships, they can be very transactional still. You know, it's I give a bit of this and I take a bit of this. And I think Mark, he's probably not here anymore, but he made at some point about cultural, operational, and regulatory barriers. And I think the culture is really, really important when you want to have open innovation. And when you really want to tackle these global challenges and you want to bring industry and you want to bring universities and you want to bring CROs and research councils together. So they have very different cultures. So the culture aspect is important. So Shinogi approaches this as wanting to build very long-lasting relationships with key universities and other stakeholders in this system. During the break, I just talked to Vera from Imperial College Business School, from Corporate Liaison, about the fact that we have invested now 1.5 years to build a relationship between Shinogi and Imperial, and this relationship is now really bearing fruit. So we believe in not transactional, but really relationship building. I think it's important to explore new modalities of engagement and to create circumstances of serendipity. I think that's also extremely important by forming relationships and having close proximity. And to come to your question, Shinogi, one of our core therapeutic areas is infectious diseases, and we're very excited. I mean, earlier on we heard about how Big Pharma is moving away from neuroscience. Big Pharma is also believed to move away from antibiotic development. These are two areas where Shinogi these are our core therapeutic areas. And we are very keen in 2 years' time to introduce a next generation cephalosporin. That's a very important compound to us. And we are now wanting to understand how we deal in Europe, how we deal globally with infection control. We heard the challenge James introduced in antimicrobial resistance. And we are very keen that when we introduce our next generation cephalosporin, that we use it intelligently, smartly, that we give it to the right patient in the right dose at the right time. And here is an example of this new sort of mode of engagement in an open science way. So we teamed up with a technology developer in Germany in the area of knowledge management. We had discussions with Imperial College and with Alison Holmes and the Antimicrobial Resistance Initiative and with the NHS, and Shinogi participates in it. And what we're trying to do is to capture patient data, treatment data, pathogen data, and facility data from intensive care units, first in the UK and then across Europe. And we're trying to integrate this data into a knowledge network map. And what we're then trying to do is we're trying to take this data-driven approach to replace what we call therapeutic drug monitoring. So if a patient comes to an intensive care unit and can stay there for weeks, there is a period of 72 hours where essentially the antibiotic concentration is quite empirical, the antibiotic that's being given, how the antibiotic concentration is measured, and then over 72 days it's sort of determined at a therapeutic dose. And we're trying to replace this 72 empirical period by a data-driven approach where we give the right antibiotic at the right dose immediately to the patient. And that's an example where you have a technology developer, a pharmaceutical company, major university, and the NHS working together. These are early stage discussions, but we think we will overcome the barriers to this happening. Now, that's an open science approach. This knowledge network map we will publish and make available to everyone, to Public Health England, to other pharmaceutical companies. It will be truly available to everyone. But then I think it's important universities now challenged to have the third way to generate economic value, especially in the UK. So there's an important, that there can also be a commercial opportunity. So after we have generated this model, this knowledge network map, any company, including Shinogi, who wants to model their own data into this, will then interact and have a commercial relationship with the technology provider and the university. So that's how we have a truly open science project that has also got some commercial potential and is truly to the benefit of all. And I think that's an example of new modalities of engagement. I'll probably stop here.
Okay, thank you very much. Just speaking on these collaborative models, I'll perhaps move to Ted. Ted, you have been an innovator yourself, and you represent the other side, or it should be the other collaborative side, that is the academia, but also clinical practice. Can you share a bit of your experience on the collaborative models and these perhaps different incentives that academia might have and the industry might have?
Yeah. I mean, I guess one of the problems is this notion of it being the other side, and I'll sort of come back to that in a moment. But one of the issues that organisations like the hospital that I work in has is knowing what its IP portfolio is. What are the potentially commercial innovations that are being developed under the roof of the organisation? So I think, I mean, to give an example of that is if I turn the clock back 20 years, when I was doing my PhD, we had a new toy which was an imaging device which had diagnostic potential in an eye condition called glaucoma, and I thought, well, okay, let's develop a diagnostic algorithm, which I did, published, and we just gave it to the manufacturer that built the device, which probably wouldn't happen now. It did mean that we've now got a very good relationship with that particular company, because I think we're good value for them. But there needs to be proper infrastructure in these organisations to, I think, proactively identify the IP that's being developed and develop teams to support. Very often it's the junior people who have these good ideas before the sort of 30 years of decline and bitterness that happens thereafter. So there need to be teams to support sort of speed dating, if you like, to match the innovator with all the different skill sets that are needed to help bring an idea through development into something that's actually a commercially viable product at the end of the day. And resources need to be given to that. So I've been in the situation before where we've had IP that we wanted to license to a company, and the company waited so long for the tech transfer to respond, they walked away. So maybe that's a question of it not being taken seriously enough by universities and hospitals. To go back to the question, though, of this sort of artificial divide between academia and business, I've got a project at the moment that's funded by the NIHR Eye for Eye program system. And we've got 2 patents that have been filed. There's a year left to go in the project, and my very valuable postdoc, who's the sort of core of the project, has said, well, you know, there's uncertainty, there's only a year left. I've had to start looking for other positions. He's got an offer from another university for a lectureship, but he said, I'm also asking industry. And of course, he's asking the company that we've been talking to for licensing the technology. My response to that was, well, great, actually, have that discussion with industry, and let's see if we can come up with a joint job plan that's part funded by industry and part funded by the university. So he put that to the company, and the company said, great, we very much like the idea of partnering with universities. So my job now is to take that forward with the university and see how receptive they will be, because they're always risk averse and there are sensitivities around IP and who owns it. But that's maybe something that is a challenge that we'll have to meet.
Does any of the industry would like to react to the risk aversion highlighted by, or the over cautiously highlighted by Ted?
Well,
and how that hinders these collaboration models?
I completely agree. Shinogi, as our innovation office, we gravitate to universities that are flexible, that want to explore areas of common interest from the bottom up, and that find that nucleus where there's academic curiosity and there's benefit to industry, and who then creatively look at how we can manage, how we can fund it, and how we can deal with the IP issue to, you know, so IP is such a hindrance at the early stages of collaboration. So really, and some universities are very straightforward, and it's easy to deal with. Others have actually, sadly, in my home country, I shouldn't really say that, but which you probably heard from the accent, is Germany. So there's walls and walls and layers of processes to go through before we can actually talk to an academic. And whilst there is excellent science and medical research in Germany, it simply is very laborious to go through these layers, and often it doesn't result in something productive. So there are other innovation-friendly countries and universities that have actually streamlined this process and made it less bureaucratic. So a very important point.
Just perhaps speak on another point that was raised by Kai, the importance of data in addressing these big challenges. I'll move to Evalota. Evalota, your company is at the cutting edge of personalized medicine, and you'd like to share, if you could share your ideas and your experience on what are the key steps that we need to have in place to move towards a cost-effective personalized medicine model, and what is the role of big data in that?
Yes, thank you. So I wouldn't say we're quite there yet. We're still very early stage and we're aspiring to get to personalised medicine. And I think I'll refer to what the previous panel also discussed in that, you know, it starts very early on when you're doing drug discovery. You need to first of all make sure that you have very good disease targets to try to lower the attrition and, you know, lower the risk, the risk of failure. So for those who don't know, we're a private biotech that came out of Oxford University. Our founder and CSO worked on T cells back in the 90s when it wasn't fashionable and nobody worked on T cell. And it took him to about 99 when he realized that actually to make something out of this innovation and make it an entity, a new molecular entity, he needed to leave academia and actually set up a company. So we remained private. We initially were funded by two high net worth individuals who believe in this Danish individual who had the great ideas, and the story started there. So it's been a very long journey, and I think over the last 5 or 6 years we have dramatically improved how we're trying to lower the level of attrition by, for example, looking at disease targets, novel and existing disease targets, and look at in cancer to make sure that they're highly expressed in the cancer tumor, but at the same time looking at enormous amount of healthy tissue from different organs to ensure that those disease targets are not present there. So our technology cannot be tested in animals because it's a fully human entity. So we need to do a lot of testing preclinically before we go in to test in patients. And that's why it becomes even more important to collate data about different organs, but about different patients, RNA level data, enormous amount of different types of screening. And we're generating big data internally, but also accessing data externally from databases that we then harness and collate in order to use that and translate that to something meaningful for the patients. So we use, of course, diagnostics and biomarkers to then end up in a clinical setting where you're trying to ensure that you're not treating patients who will not respond to that new drug. And you see a lot of new drugs coming through in immune oncology, which is the area we're in, for example, checkpoint inhibitors, and they've had a great success. But already you see that a lot of patients are not responding. You know, they may express the disease target, but there are other factors that come into play. So we need to kind of travel the journey to kind of go towards understanding that better, and that will take some years still to come. So from 1999, when the company was established, you know, we've made sure that we have a very robust platform. We started testing in patients, and we're now at the point that we're initiating what's called pivotal studies or registration studies that will take us to the product to market. And that is in a very rare eye disease. It's a melanoma of the eye called ocular or uveal melanoma. It's rare, so it's clearly we need to make sure that patients that we're going to treat have the target, the disease target that we're looking for. But we also have another restriction, and that is what's called an HLA restriction. So we need to make sure that these patients also have the correct HLA before we actually start treating them. And with that in mind, we're hoping then that we can actually increase the success in the clinical studies that will then lead to a successful drug that we can take to market.
Thank you very much. Very interesting. You mentioned always failure as a challenge, and Rifat today highlighted failure actually as an opportunity. And my question to you is, can we use models of open innovation or sharing experiences on failure to generate further and better innovation?
So I certainly think that, you know, over the next coming years, this will continue to improve. You know, we're not there yet as a company, and I would, you know, be lying if I said we were. We're far away from getting to the sort of ideal world of personalized medicine. But what we've done even in the last 4 years is to establish, we had an IT department and then we had lots of scientists, but we had nobody that can communicate in between. So we've established what we call scientific computing group that actually communicates between these two. Take the innovation and translate it in this big data, to collate it and actually translate it into databases for us, which then eventually can be communicated back to IT to ensure that we have the right infrastructure. So I don't know, it's a difficult question to answer, but there's still quite some way to go. But I think any issue should obviously, or any problem should obviously be a challenge to be overcome.
Thank you. Cyril, so what is your perspective on the challenges of developing a new drug? Are you facing the same challenges, and are the enablers of innovation that we've just heard now across the different sectors common, shared also in the medical devices industry?
Yeah, sure. So Smith & Nephew is about a 5 billion business. We've been around for 140 years, so we're a rather mature company. We do 3 things. We do technologies to repair joints, ligaments, tendons. When they don't work anymore, we change them, change a knee, change a hip. And then we also do wound care products for the very bad wounds that you need to heal in the hospital context. The way we look at innovation is that the era of traditional innovation is not dead. We continue to invest 5% of our revenues in R&D. We invent products and we put them to market. That's going to continue for the foreseeable future. It needs to be complemented, though, by another approach where you think of innovation as going beyond just the products, but thinking of innovation as addressing a problem. And addressing a problem can be through science, for sure, but it can also be through a design, through a business model, or through combining a product with a service, right? So let me give examples, because I think it probably speaks more. So we've invented a great knee. It's made up of a material that's called oxinium. It's so strong it will last longer than other knees. And it's been designed with a ton of modeling, and it's very kinematic. When you put it in, it feels like it's your knee. Okay? Great product, right? We spent money and years developing it, brought it to market. And our clients, surgeons, they love it, right? Of course they love it. But hospitals hate the price of it. It's very difficult to get a premium price because the hospitals say, I've got a knee that lasts 10 years, so yeah, for sure, yours will last 30, but I'm not going to see the benefit of that for another, 10 years at least. So, we're struggling to get a good premium for that innovation. Well, we're still very happy we did it, we're selling it well and stuff. But that tells you that your innovation for a company like us that is at a mature stage is about, not only is it about tomorrow's technology, not the day after tomorrow, because we cannot invest for 30 years from now. We've got to invest in products that get results. Not only is it about that, but it's about value. It's about the value you bring to the system. Look, there is a finite amount of money in the healthcare system. If you come in with an expensive product, you're hoping to take the money from someone else's pocket. That's difficult. That's difficult, right? And if you come up with a very expensive product that people can't afford, you're like selling luxury goods in a refugee camp, right? Right? You don't want to be in that position. So the way to think about innovation is, how do I make sure that my innovation adds value? So let me give you another example. In our wound care business, we have a technology called negative pressure. What it consists in is when there is a wound, you put a dressing on the wound, you attach a pump to the dressing, the pump creates a vacuum, it accelerates the blood flow to the wound and accelerates the healing of the wound. Simple, it's been around for years, and we're one of the players in that market, actually one of 2 large players. Great product, except the patient is in a hospital bed with this tubing system and this pump by the bedside. Patient is in the hospital. You want to see what value looks like? I'll show you what value looks like. Value looks like that. It's a pump, except it's a small pump. It can be carried around. So what you do, it lasts 2 weeks, it's got a battery, it's got an indicator in case there is a leak. So what you do is, once the patient is in your hospital, you apply that product, get the patient back home, save a bed, create value. also create quality of life for the patient, by the way. Pretty important. That's innovation that creates value. Creates value to the system, it creates value to the patient, creates value to the caregiver, easy to use. Needless to say, we're selling a lot of those, right? A lot more than pumps. They're single use, recyclable. Pretty good innovation in my view. I think that's the sort of thing that we're trying to get towards, and that's the kind of thing that really generates value for the system. So think of innovation as not only science, but resolving a problem, too many people in the hospital, too costly. And think of innovation as something that needs to bring value. Start from there, and then imagine your development plan to get to that.
That's very interesting that you touched on the barriers to adoption of innovation, and you mentioned how much it costs to hospitals, and you somehow presented that if you have a good innovation that brings value, it's automatically, almost automatically going to be adopted in practice. Yet we know through research that we do here at the business school with some colleagues, for example, we're looking at laparoscopic surgery for colorectal cancer, and for the group of patients that will benefit from that treatment, that we know it's cost effective, we still see that despite it has been introduced in the late 90s, there's still a substantial amount of consultants that don't adopt that innovation. So is ensuring that there is value enough, or what else do we need to do in order to speed up that adoption of innovation within healthcare systems?
That's a tough question. I'll answer slightly besides the point, but hopefully you'll see where I'm going. If you start from a need, your adoption becomes somewhat easy. You've got, of course, address the problem, right? So here is another problem that we looked at addressing. In emerging markets, where we have about 15% of our revenues, we were among the first ones to be in emerging markets, and in our medtech industry, not many people have that much of the revenues in emerging markets. And there, we started with selling our high-end products to the affluent part of the population. Those that could afford it bought it, great, but not sufficient, because we were not addressing the need of the emerging population, the emerging middle class, that was looking for care but could not afford the top end. So the immediate response to that is drop your prices. Not very satisfactory. Let me tell you, our shareholders expect a return. They don't expect us to go and sell products at a loss or at a low margin in emerging markets in a risky area. So you've got to think of things differently. So when you think of something that can be adopted by that population, what they want is they want something that is good, but that's affordable. So you got to, again, reverse engineer. Start from the problem, get to the solution. So the solution was, in our industry, we've got 75% of our revenues in cost, right? These costs are manufacturing the product, selling the product, and training your surgeons on using your products, right? Or the doctors or the nurses. These are our costs. So you think about it, say, what innovation is going to get me something that reduces those costs and therefore allows me to have a lower price point and still retain an acceptable margin that my shareholders will support. So we went back and we said we need simple design so that we have simplicity of use, simplicity of adoption, but it needs to be a good quality product because it's a Smith & Nephew product, right? We're putting our brand on it. So we reverse design technology that was not new science, it was stuff that already existed, but we redesigned it in a way that it was going to be simple to use, simple to sell, simple to adopt, and we're selling it at a price point that is, close to half of where we would sell our high-end. Let me tell you, for the person that used to be in a wheelchair and can now walk, that's innovation.
Yes, please.
I think it's a really good point, because there's another innovation that we haven't talked about much today, and that is in education and training. So I think that the next generation of innovators will have a very different skill set. Universities have up to this point a sort of memorized knowledge model. But now, there's a new world, so we need to have people who can search for information, who can authenticate information, who can integrate and transfer information. And these are very different skill set, and they will be the innovators of tomorrow. And I think the role of universities is incredibly important in teaching these skills as well as entrepreneurial skills, so that we're filling the skills gap and we're having people who can seamlessly go between the different stakeholders in the innovation system. And that was a wonderful example of that transfer of innovation. Another one I heard recently by Sir Andrew Whitty, who said that one of the most exciting things that he saw in GSK in the last year or so was a graduate who actually took an Xbox Kinect system. If you're not familiar with this is a sort of camera that can capture movement, to actually apply to a manufacturing facility in GSK to have real-time monitoring of manufacturing inefficiencies. So that's another example of transferring something from a video game console to following in real-time inefficiency in a manufacturing facility. So I think this skill set is incredibly important, and engaging with the minds of these people, this new generation of innovators, is important, and that's where universities have a fundamental role, I believe.
Thank you very much. We have been reminded we have 4 minutes, so I'll open the discussion to the audience. If you would like to make a question, yes, just introduce yourself and maybe direct a question to the panel. Thank you. To the person in the panel.
Thank you. Cyril, it sounds like there's two kinds of innovation. I mean, if you're going to create value that where everybody's incentives are in line, you're going to make a lot of pumps, but you're not going to make that many knees, because you have an easier sell with the pumps than with the knees. So that you would, in some sense, shift away from creating certain kind of value to the patient. That's my one question. And the other one is about this introducing design solutions to bring, when you've got a better design, that product, that actually becomes your new high end. That's actually the one that you're going to then sell to the high end customers at a higher margin.
Yeah. So let me start with the second one. You're right, but again, you've got to think of the universe as being a universe of a finite amount of money, or very low growth in the money available for healthcare. You've got to think about that, and probably a lot of unmet needs anyway with the money we already have today. So this whole concept that you can sell something very expensive, yeah, probably, but in terms of mass market, more difficult. I wanna just say on the second step of your reasoning, which is once you have the new high end, maybe your former high end becomes your low end. Unfortunately, that doesn't work. That doesn't work. Speccing down never works. If you put a scientist that's used to, or a research person that's used to develop super products, and you say, can you down feature it so that I can sell it for less in emerging markets, never works. Mm-hmm. You've got to invent it so that it can be sold in that emerging market, right? So it's that part. Now, to your point about you would want to sell a lot of pumps or a lot of it. Look, it's two different businesses. They're related. Obviously, you got the fact that when you do a surgery, you have an incision. On the incision, you put the wound care product. That's the logic of having that in the same portfolio for us. But it's two different business models, right? You address a wound. You address the diabetic foot ulcer. These are really bad things. By the way, I hope you never have to use our products, right? but if you do need them, we'll get you back on your feet. These are really bad wounds. The other one is it's a different pathology, right? So you need both, and we're in both of those businesses, but more importantly, we're in both of those care areas.
More questions? Guy in the back. And then there.
Hi, just a question perhaps most relevant to Kai, but when you think about harnessing innovation for sustainable global health, how do you harness innovation where there's a desperate need for sustainable global health? And I'm thinking of microbial resistance here, which is truly at epidemic proportions, and the statistics keep on getting worse year after year, as we all know. But the economic model remains broken. So the situation is getting worse, but companies like you are unable to innovate in the right way because, certainly in Europe anyway, the economic model is broken. And all these other wonderful innovations, frankly, mean nothing unless this issue is dealt with, because people are going into hospital to get a simple knee operation and are ending up in a bed for 4 weeks because they've gotten they're infected and penicillin drips, etc. So that's I think you get my drift, but I'm just curious how you would answer that and what the perspectives of Shionogi are on that.
I think that's an excellent question. Thank you. I think in two ways. So, firstly, antimicrobial resistance is a global challenge. It doesn't know any boundaries, any artificial country boundaries. So we are not simply wanting to come to Europe or globally to the world to take cefiderocol, which is our next cephalosporin antibiotic, and convince people, to sell it here. So we want to contribute to the community. So I mentioned the big data project, which is all about giving the right antibiotic at the right time at the right dose, so that we're actually really combating antimicrobial resistance. We're also engaging with some very early startup companies that use CRISPR-based phage-mit approaches to actually make a probiotic to essentially transfer CRISPR cassettes across bacteria through transposon transfer to actually remove antimicrobial resistance genes. That's a very early stage technology. It's a very early stage startup, but we are actually working with them to essentially develop a probiotic to remove antimicrobial resistance. So we're wanting to interact with the community, not just trying to sell our antibiotic. So that's one approach we take. In terms of reimbursement, you are absolutely right. I think we have to go and look at this globally. We have to go to the G7, G20. We have to have independent organizations that reimburse pharmaceutical companies that are willing to develop antibiotics, because the trials are hugely expensive. And quite frankly, if our antibiotic is used as a last choice, then we will never recuperate the costs that we had in development. So this has to be tackled globally. And I think Mark alluded to it. You'll probably find it in his book, that we need new reimbursement models that tackle it globally.
Thank you. Thank you very much. We don't have much more time, and I don't want to be between you and lunch. I'll just wrap up. I think what we've learned today here with the speakers is that, well, there's two key messages, is that value is very important, but it's even more important to ensure that the environment, and environment meaning delivery models, design, education, financing, there's also innovation in that space to enable an effective diffusion of innovation. And I think you're going to touch in some of these issues this afternoon. So I'd like to invite you to thank to our speakers today, and to all of you. And I think it's lunch, right? No.
Are they here? I've seen Cassie.
Sorry, he's here. Sorry, can I emailed him before.
Yes.
Oh, did you? Which I used to work at.
Thanks, Mark. Got a mixed panel. That was about.
I know.
There's some common themes coming through. I think. Yeah. But I mean, there are 3 or 4 things coming out of this whole morning, I think.
Sorry, Rufat.
All right.
So thank you very much. I'm very pleased to have such a high quality. Thank you. I'm very pleased to have such a high quality panel to conclude our morning session. So we have Michele Colucci, who will moderate the discussion. Michele is a global co-head of healthcare investment banking at Morgan Stanley. He is also the chairman of mergers and acquisition for Europe, Middle East, and Africa. Throughout his career, Michele has advised companies on many transactions. These transactions have helped to shape the healthcare industry as we know it today. He has provided such strategic advice and assisted companies in raising capital to fund their growth. Michele is also a Harvard alumnus, and we are delighted to have him today. Michele, I will let you introduce Kate and Kasim, who I understand you know very well, and we're all delighted to have you here today. Thank you very much.
Perfect. Thank you. Are these mics live? You can hear. Yeah. So excellent and very experienced panelists. We've known each other a long time. Kate and I were at Harvard Business School together. She was a Baker Scholar. I was not. But other than that small detail, I think Kate is probably one of the most experienced venture capitalists in the life science area at SV Life Science since '91. The dinosaurs still refer to it as Schroeder Ventures, but it is SV Life Sciences. And fair to say that especially in the European context, there are a few people of your generation with as much experience and exposure. So terrific to have you here. Kasim is in the very privileged seat of being the CEO of the Novo Foundation. The Novo Foundation has about 45 billion in assets and has a wonderful business model, which is there's huge dividends coming from the assets that it manages, and in particular controlling stakes in Novo Nordisk and in Novozymes. The mission is to invest it in life science-oriented ventures. So a very prominent seat from which to speak in both cases. What I'd like to do is start maybe as we're changing tacks towards innovation is important, so how do we fund it? I think each of you has a very interesting perspective on the evolution of innovation in healthcare and on different models on how to fund it. I'd like to start with Kate because SV Life Science has actually been pushing the envelope on funding models, especially in a context where venture capitalists in Europe have been looking for new models, and maybe there has been less innovation here than, say, in Cambridge, the other one. And so one of the most visible has been the setting up of the Dementia Discovery Fund. And what I'd like to ask you, Kate, is tell us, why did it need a new model? And why did it need venture capitalists? And how do you see the development of the fund?
Sure, thank you, Michele. So, is this working? Is this right? So, what we helped launch was a new fund called the Dementia Discovery Fund. It is not, in fact, a European fund. It's a global fund. It's been funded globally. It is sourcing science globally. And the mission of the fund is in the name. So, as you all know, because I suspect everybody knows family members or friends who've had some form of dementia, Alzheimer's, there are no drugs that can alter the course of the disease. We have some drugs that can address some of the symptoms transiently for some patients, but otherwise it is a programmed course of deterioration, and it's a disease that takes sort of 8 to 10 years before you finally die. So this is a catastrophic, very serious disease facing the Western world, for which there are no solutions. So this was an incredibly creative vehicle that actually was started originally by the Department of Health and the World Dementia Council. So the idea was, how can we harness the knowledge that exists both in industry as well as in academia to actually come together, share that the experience and expertise in order to find drugs that can alter the course of the disease. So instead of just telling somebody how slowly they're going to deteriorate and the likely course of the rest of their life, actually do something about it. So arrest the course of the disease, identify patients early, treat aggressively so that you can either delay or prevent the deterioration of disease. Much like we've done in heart failure. We don't wait for people to have heart attacks and then say, oops, you're high risk and now we'll start treating you. We identify those patients early and we treat heavily. So the goal of the Dementia Fund is to share the knowledge that is out there, and with a very specific mission. We are not going to, and for the biologists around here, we are not going to focus on amyloid beta. So this is a
a biological hypothesis which says you get sticky proteins in the brain called amyloid. They clump together, they form plaques. At some point, that drives neurotoxicity, so it kills the brain cells, and that leads to a death over 8 to 10 years. So that has been pretty well explored by industry and academia. Not to say it's failed, but so far no drugs have yet come out of it. So we are actually taking a different approach, which is to look explicitly outside every other area of biology to figure out what are those different ways that we can where we can intervene that can actually affect the course of the disease. And Chaz sitting in front here is a very key part of this new fund. So this is the first time that you have government, actually a charity, Alzheimer Research UK, 6 pharmaceutical companies, including Janssen, that put up the first $100 million to say we want to do something differently. We will share not only our expertise internally, we will put up the money, and we will work with you to try and figure out what are the new ways that we can actually start looking at to develop new drugs. And so what we've done at SV has been to recruit a team of neuroscientists into our investing team. So that, again, highly unusual. Mostly venture capitalists recruit people with investment track records so that we can then go back to our investors and say, look, this person's made money, you should give us some more. And so what we've done here is we've matched people like me with an investing track record with teams that are card-carrying neuroscience drug discovery teams, know nothing about investing, but they know about what a drug looks like and how you get a novel drug, translate that from preclinical models into patients and to market. And we've basically put those 2 teams together and said, this is the way we are going to figure out how to get drugs that work. So now the model we've got is we've got a team internally, who are neuroscientists, with a very clear task to say, don't look in the same places that everybody else has drilled. We want you to look outside that. And you know what? The fact that neuroscientists think the brain is a very discrete place, the fact is it is attached to the rest of the body, so it's not unlikely that there will be biological processes happening in immunology and inflammation, in oncology, which you could apply to the brain. And then working very closely with the pharmaceutical companies who each have put up their heads of neuroscience or their heads of CNS to advise us on how we develop new drugs. So it's massively exciting. It's never been done before. We've never seen this level of collaboration. And if we're successful, it will be a complete blowout fund, because if you can imagine, there's 45 million patients with dementia now. That's going to go up to 140 by 2050. So it's a massive, massive global challenge. And the cost of looking after those patients is phenomenal. So it's not the drug cost, because there are no drugs to give them. It's just the massive human cost of caring for these patients. So we're not short of a commercial opportunity. And we've got a great, I'll stop now very quickly, but there's a fantastic track record in oncology where 15 years ago we used to talk about cancer of the organs, so cancer of the breast or the colorectal cancer or lung cancer. Now we talk about HER2 positive breast cancer or triple negative. So we talk about the cancers according to the molecular drivers that cause the cancer, much as Eva Lotte was talking about. In dementia, we still talk about dementia. We still talk about Alzheimer's. Alzheimer's will be lots of different diseases that is causing ultimately the same neurodegeneration. So that is, we now know that as the world has been able to harness molecular understanding to develop these targeted drugs, just hasn't been done in dementia. People are scared of it. And so we are going to nail it, and that's what we're going to be doing.
And Qasim, I'll get to you in a second. But Kate, how long did it take to put this effort together, and who drove it?
So we did not drive it. David Cameron, when he was chairman of the G8, as it was then, set up the World Dementia Council and said, basically, this is a global problem. We've failed to deliver any effective therapies. And so said to the World Dementia Council, what should you do to make this work? And there's different drivers, but there are 2 key drivers. One is complete lack of new molecules being tested. So lack of innovation coming in at the front end, and then difficult trials and difficult and long regulatory process on the back end. So the World Dementia Council said, actually, the way you can try and address the innovation is to put it in the hands of VCs, because VCs are very hard-nosed. They're good at going out and finding novel biology. They have to put their own money in, so they're very focused on not spending money if it's not going to work, and they're very focused on trying to make successes. So the recommendation was, let's create a dedicated venture fund with a very clear mission and harness industry expertise. And then they ran a beauty parade. So I was called up by the pharma guys, and as was 20 other VCs, mostly American-based, saying, did we want to do it? And having understood it, I thought, yes, I do want to do it, because it's a huge potential opportunity. And now I know how the fund has worked, because we've had a team together probably for about a year now. I would raise every venture fund like it, because what's not to like? Yeah, you're leveraging external expertise, and it's non-competitive, because that's the question that everyone comes back with is, well, why will the pharma companies help? And the fact is, in these big pharmaceutical companies, they have to be focused, and they simply can't do the breadth of exploration that we can do in a venture fund. So we were fortunate to be chosen as manager, and the team, as I said, has been together a year. We've invested about 10% of the fund in about 10 different very early projects through to late stage companies.
You probably benefited from the fact that as you were setting it up, all the pharma companies were headlong in amyloid. And these were the non-amyloid marginal, as it were, at the time, not so marginal today. So this is a poster child, obviously, of how you set up some research in areas that are less amenable to the big commercial, large pharma economics. But the other way to do it, Qasem, is through foundations.
Yeah.
And I think the Novo Foundation has the benefit, I think, of being extremely low-key, but at the same time having possibly the best capitalized healthcare resources, which is a very powerful combination, which allows you to set the direction with an enormous amount of flexibility. So how do you look at innovation? And as the incoming CEO, where do you think you might actually try to bend it towards?
Thanks, Michele. I think it's important, before answering the question, just to put something in context, which is dementia, Parkinson's aside, and some other disease states, we are witnessing an incredible revolution in R&D and innovation. Up to about 4 or 5 years ago, it was a sad state of affairs, and the world was lamenting the billions that pharma companies and others had invested in R&D without getting a whole lot out, and R&D productivity was very low. But you look at what's happened in the last few years, and everybody talks about, of course, oncology and immunotherapy, and that's the poster child of the advances that have taken place in medicine. We have high-profile people like Jimmy Carter, who thought he was terminally ill and was told he was terminally ill, and thanks to an immunotherapeutic was alive and was in remission. And that applies to other areas. If you look at what's going on in multiple sclerosis today, a neurological disease, but obviously very different from Parkinson's or Alzheimer's or dementia, unbelievable progress in multiple sclerosis. So there's a ton of amazing stuff going on, which is very important. And that's certainly my view and the view of Novo AS. So actually, we are ramping up very aggressively. We're putting more money to work than ever before, whether they be in single transactions or into our in-house funds, which are wholly owned by us. We're the only investor in those funds. Michele, to specifically answer your question, how do we fund innovation? And I think what Kate outlined is really important for the future, because I think for the very difficult to treat diseases, such as dementia, Parkinson's, and for diseases that I was referring to earlier, the microbial resistance, it needs a new and fresh approach. You can't keep on banging your head against the wall with this. So it's really great to hear what Kate is doing, because that's what's required. So what are we doing? I'll give you a couple of examples. So one of our funds is what we call the seed fund. So that's a fund that helps early stage startups. And the way we try and fund innovation there is twofold. Number one, we don't wait for the scientist or for the person with the brilliant idea to get the courage or decide or figure out
how they're going to fund something, on how they're going to set up a company. We actually proactively go out and scout and actually encourage people to say, look, you're doing something very interesting here. Well, that's a very interesting molecule you're working on. We can help you set something up around that. So that's one important thing. So a really, really strong scouting capability at the seed level. So we're not waiting for people to knock on our door, which is actually quite rare in venture capital. A lot of venture capitals wait for something to land, they take a view, and then they decide to invest. So we scout. And then number two, what we found to be the really gating item at the early stages was not the quality of the science, particularly in today's era where, as I said, we're witnessing incredible innovation. So science is not the gating item for us. The gating item is the commercial infrastructure. You know, for people who have spent their life in a lab or have a great scientific idea, you know, for the businessmen in this room or people who study business, we take a lot of things for granted. For the scientist, setting up a company, fundraising, putting a business plan, these are really, really tough things. So what we pride ourselves in doing is actually setting up that commercial infrastructure. So not only going up to somebody and saying, we have a great idea and here's a check. It's what do you do with that check? How do you build a team? How do you recruit a team? How do you put a business plan together? How do you go out and do your Fund A series round and Fund B, et cetera? And guess what the gating item was? The gating item was management, CEOs. So that the science is there, the scientist is there, the molecule is there, the pipeline is there. But where's the scientist? Where's the management team? And there's a real dearth of what we found, certainly in the area we operate in the Nordic region, to find CEOs that are capable, have the experience, and are willing to go in and manage these companies to a stage where they can fundraise. So what we've done, and where we've tried to be creative about, is create something called an Entrepreneurs in Residence program. So we take a group of people that we've worked with successfully, and once a company is sold or is partnered or whatever, we don't let them go. We say, come and stay with us. We give them a salary, we fund them, we support them, until we find the next right idea, and then we parachute them in. It's a small group right now. It's less than a handful of people, but we think we're going to grow it to at least 7, 8 people. And that is a creative way of dealing with the gating item of making sure that good science gets good management and a good commercial infrastructure. So that's one example. Another example, and this is very early days, very, very early days, and I can't say too much about it, but on the microbial resistance front, which is really a big issue, what we're going to try and do there is set up an impact fund. So we're going to try and invest without the ambition of making returns, because if you do that, anti-infective research is not going to get any backing, because you run the models and you run the numbers and it just doesn't stack up. So what we're going to try and say is we just want it to be self-sustaining. We want it to make just a 1x return or a little bit over, because we want it to keep on being able to invest. And we are going to try and, for the first time, potentially, not just do it with our own money, but go and, frankly, try and mobilize some other political institutions, NGOs, et cetera, to really make sure that, because a lot of people are focused on this issue, they just don't know what to do about it. And we're going to try and do, so that's another example. Obviously, lots of other, but I'll just stop there, because I think those are two very, very interesting and prominent examples.
And do you, as you run the innovation end, and obviously you just became the proud owner of a large piece of Convatec, you're going to be on the board of Convatec, that is a terrific company. It's not on the innovation end that we're discussing today. If you start looking at the innovation and science, and particular, we're discussing methicillin resistance or whatever. Do you have a target in mind that some of your funds will be invested in these low return kind of orphan areas, or is it more that as you see ideas, you're open-minded about it?
No, we're very fortunate in one way, which is two things. Number one, we invest across all the classes, all company stages, from a seed fund all the way to a deal we announced yesterday for over £1 billion in one deal where we took 20% of an LSE, London Stock Exchange listed company called Convatec, which is a key competitor to Smith & Nephew. We were hearing from Cyril about Smith & Nephew yesterday. So You're absolutely right, mate. So we have that at the large end, where literally it's £1 billion in one investment. And then we've got our seed fund that's doing 5 to 10 to 15 million. And it's really, I'd say a lot of the orphan investing is done through our seed fund. And they executed on their first IPO ever a few weeks ago, a company called Lysogene in France, which treats a rare orphan disease, so classic example. And then our venture fund as well, which backs orphan diseases. But again, in some ways, those are much easier than the microbial point, because there the models work, and we're investing for a financial purpose. And because of the pricing of rare diseases, which, as you know, is highly attractive, even though the pressure is on, it's still highly attractive, the numbers work. So that's pretty, for me, the orphan side of things is pretty straightforward. The less straightforward side is how do you fund diseases where the economic model is broken?
Yeah. And maybe I should give sort of a 2 or 3 minute context from the capital markets perspective, which is, the markets work where the numbers are commercially attractive, just to state the obvious, right? We're in a business school context here. So if you ask, and there are a number of representatives of large cap pharma here, but if you ask most of them, what is the key driver at this point that your board, your management is aiming towards, the answer is always the same, which is growth. And growth is units times revenue, and the issue is generally not the number of units, but the revenue that you can get longer term in the business lines that you're in. So if you start looking at immuno-oncology, for instance, if you start looking at CAR-T, the revenues are driven not by the numbers, but by the revenue per therapy, which is obviously now the issue as we're developing, and there are a number of companies with very strong positions in that area. The historical model for large cap pharma innovating, in many ways, and discussing now sort of the one that involves investors and capital markets, is probably 25 years old now, and people continue to talk about Roche Genentech. And Roche Genentech is still the model, early 90s. You had Roche, was then, is now probably one of the best science-oriented large cap pharmas in some traditional areas. And then you had Genentech on the West Coast beginning to develop a completely new type of research. And the two models couldn't have been further apart physically as well. You had Basel and you had San Francisco, completely different types of employees and culture. And Roche, just to go back through history, had the breakthrough that basically said the two cultures can coexist. And the answer at the time was, let's leave Genentech as a listed company so that they can talk about their options over lunch, which seemed to drive scientists then, as it does now, very efficiently. And we won't bother them with that as long as they supply the goods. And as we all know, the movie then progressed through various iterations where at the end, Roche decided this is so good, we're going to own 100%. But if you look at the Roche pipeline today, it is still very much driven from that seminal idea in the early 90s, because a lot of it is coming from Genentech. So that's the model, large cap pharma looking for small innovative companies, and you can look at Sanofi and Regeneron, you can look at a number of different models. But to do that, you need a startup company that has a sufficiently clear business model that corporate investors accept the trade-off of taking a stake. And what we're finding now, if I look at it as an investment banker, is that a lot of these models, especially in the very interesting early science, are much more difficult to prove. And so companies are looking earlier and earlier in the development life cycle, but it's very difficult to go to a board and basically say, here's our great idea. The general discussion is, do they have a marketed product? No. Do they have a phase 3 product? Well, not yet. Do they have a phase 2 product? We think next year. Do they have any data? And you know which one I'm about to mention. No, they haven't published any. So, so that puts investment and innovation in a completely different context. And you know, to the question, what will large cap pharma do going forward? My own view is that they will learn how to become risk managers on science much more proactively. In other words, the idea that large cap pharma can only look at published research externally, I think is going to go away, and they will become risk manager of multiple products.
So, I mean, as an example, I'm working on 2 deals outside dementia. So I wear 2 hats. I've got my dementia fund, but I've got my normal venture fund as well. And on the other side, we're working with 2 major pharma where we have got some really novel science, so novel biological insights. And each of the pharma are having discussions with us to say, how can we collaborate with you on this without, you know, clipping your wings, capping your upside, doing anything? And they're saying, you know, what's your ask? And I say, well, we need more money. We've got you know, a very clear plan of where we want to get to. And in each case, one of them is saying, well, can we help with our chemistry? Because big pharma's generally incredibly good at chemistry. They can put a lot of money behind it, and they have a lot of access to tools and different techniques which we can't necessarily get through the small companies. And could they do that alongside us? We bring all the clever biology for no commercial rights. They're clearly at the table. They can see the data. They're engaged in what we're doing. And if they want to step in, they will have a lead ahead of anybody else. But if they do want to step in, they'll have to pay full market price because there's no special concessions given. And I've got a similar example with another company, which is, again, very different. This whole idea that we can work together with our little companies without tying them in knots, because it's not in our interest from an investment perspective to sign up deals very early. But it massively is in our interest to collaborate with people who can bring a lot of real expertise to our little companies. So it's, and I was talking to one other farmer and talking about how, what we're doing, and she said to me, so let me just get this clear. You want us to give you lots of money, you want us to collaborate on what you're doing in return for no rights? And we said, yeah. And that obviously is not the way that industry has historically gone. But we are starting to see those changes, which doesn't sort of feel like it makes sense, but actually it does make sense, because if they can get early access to really novel insights and biology, they'll be ahead of everybody else, and naturally relationships will drive deal making.
It's a very different context. I mean, I think the optimistic view that I would give is that fundraising for biotech and research continues to be enormously cyclical, and we know that. IPO cycles in biotech companies are incredibly cyclical, and we know that. But the theme of this panel being fundraising, I think the fundraising picture is much more positive today than it was 10 years ago or 15 years ago. There are significant more pools of capital, and here we're talking about 2 very major and innovative pools of capital, but obviously we have the Gates Foundation, which we haven't mentioned, but should you know, dominate many discussions, especially as you go to underfunded diseases. And you have a very interesting trickle of funding from Silicon Valley into healthcare. So from software and Silicon Valley type research models into healthcare models, which have been contiguous but are very, very different. And so even from a methodology point of view, as you get Zuckerberg saying that with, was it 3 billion or 9 billion? I can't remember.
Not sure, but yeah.
He's going to solve all diseases within the lifetime of his children, to which you know, the head of R&D at GSK said, well, it's either a good thing or a bad thing, considering we spend that amount in a quarter in R&D at GSK. So the scene is much more productive and much more innovative. But Qasim, if you look at it then from a foundation with some social responsibility, how do you see it develop from here? Is your view that early science will become the focus of some of these foundations, for example, or do you see it as still a balance between normal commercial opportunities and cooperating on science?
Look, the tough thing, and I think this is where foundations and other such institutions have a very important role to play, is the CSR one with respect to seed investing, because, and Kate will know this, but seed investing has proven to be notoriously difficult, and commercial seed funds, on the whole, have not succeeded. Now, I think with the wave of innovation that I've been talking about, you've seen a lot of funds that have pulled back, now being replaced by others. So there's renewed vigor. But for a long time, it was very, very difficult. It just didn't add up, and the returns weren't being generated. And I think, in part, people hadn't developed an effective model for seed investing, and perhaps the number of shots at goal you need to have in order to have a success. So I think that was really hampering Europe. Areas like the Nordic region are very lucky because they've got a lot of foundations, including us, who really push the funding programs very hard in order to make sure that the Nordic region remains a biotech hub in Europe, which it clearly is, particularly the area around Copenhagen. But look, I think the good news is funds are beginning to come back for startups, which is good. What's disturbing me is on the venture side of our business, where the whole CSR work is much less relevant. Our CSR work is really done out of the seeds division that with the Entrepreneurs in Residence program helping these startups. Our venture capital team are capitalist carnivores. I mean, it's they're as ruthless as the next guy in terms of counting the returns in dollars and to make them. And what disturbs me is 80% of their investments are happening in the US and 30 in Europe. And that's not because they have a bias, because frankly the HQ is here, it's in Europe. The head of the group sits in Copenhagen. But our biggest teams now are in the US. And the reason they're 80% in the US is over the last 15 years, when they look at their deals and do their lessons learned, they figured out what type of deals do they make the most money on. And every group has its strengths. But the reason they're so successful is the team has been together for so long. They've figured out where do we make money, et cetera, et cetera. And one of the criteria has been actually we make money in the US and we do it less so in Europe. Now, whether that's because the innovation is better in the US or whether because the exit environment is so much better in the US that there's just more buyers for companies, the IPO market, but whatever it is. And that for me, and I don't have an answer, and I don't know what people in this room think, and I'm not sure we'll have time for Q&A, but maybe we can discuss it at lunch. That for me is just not a nice statistic. Now, I think it's gonna shift back a bit because, as I said, I think Europe in many ways has matured from an innovation perspective, is catching up, and I think there's a lot of good stuff going on. So it wouldn't surprise me if it starts shifting back more towards Europe, but it's one hell of a shift back to go from 80, 30, 20. So, yeah, it's...
So we're 50-50 actually.
Yeah.
So in our regular funds, and we find that the issue isn't lack of innovation. So our companies...
It's not.
Is not.
Okay.
Our companies over here are cheaper, and they cost about 60% of the US equivalent to achieve the same thing. So we're seeing more US investors coming over now because there definitely is value here. The biggest problem is we have no ability to take companies public. So that we, all my exits are trade sales. Now, as an investor, that's pretty nice. I get paid up front. I get carried on getting paid when the drugs get approved. And at SV, we've now got 20 odd drugs that we invested in at an early stage that have now got to market. So, that's a nice place to be. But not having public markets is a problem. And we can dress it up, but we don't have public markets.
So you think that goes a long way in explaining why? Yeah, probably our team just feels, because they progress their companies and they feel that there's a natural exit and they can bag their return. And as I said, they are, they are very, very focused on their returns. And perhaps they invest in the US more because they just feel very confident that
it's easier.
It's easier. You've developed it.
To exit.
Bag the return.
I would actually like to leave 4 minutes for questions, and we have exactly 5. We're in the pre-lunch slot. So maybe we should ask a couple of questions to the panelists. Go ahead.
Okay, thank you. Damien Marmion, I'm the Chief Executive of AXA's Global Healthcare around the world. I've heard a lot about bioscience, and thank you for that. Some really interesting examples, and I hope that all those investments are successful in curing diseases. But we talked this morning about a higher proportion of the world's health spend being inefficient. And what funding have you seen into systems development so that we can develop more efficient systems around the world to lower the cost of healthcare for populations? Because this is really the area where, sure, there's going to be investment returns from biosciences, but there should be a greater investment from system redesign.
Great question.
Who wants to take
I'm glad you raised that, actually, because I should have brought this up in mind. But one of the things that that we've just done is, healthcare, aside from the innovation in R&D per se, where it's woefully behind, is on IT and digitization. And if you look at healthcare spend, and it's unsustainable, and IT digitization has to be a part of the solution, particularly in the US. So actually, we're making quite a we've allocated a certain amount of funds now within our venture group to invest in healthcare IT. And within our large investment team, we've acquired a company in the US for about $1.8 billion, actually a big one, called ERT, which does clinical trial data gathering with a cloud platform. So I know there's other systems, but we took a view that IT digitization as a system is going to be part of the solution of containing healthcare costs, and we are making a big bet on that. And we think that returns in the short term may not be great because it's a bit of a hot area, but and so valuations are high. But over the long term, it's going to be a key area that we're going to play in, certainly.
And we've got similar examples. So we made an investment in the US where there is legislation that requires in A&E patients getting that need a psychiatric evaluation. Well, there are lots of hospitals in the US that don't have a on-call psychiatrist, and so the investment we've made is in a telehealth ability so that A&Es can dial into a psychiatrist and get that evaluation, which means a patient, instead of hanging around forever, can then get treated immediately and sorted out. So I think IT, I would agree.
Just very quickly, Rifat at Harvard University. So we talked about funding innovation, but in health systems there's an innovation happening in funding. And as many of these molecules or NCs will come into market in 10, 15 years, the main change in funding is shift towards funding outcomes, not ingredients.
Yes.
And I think this relates to the earlier point. I mean, you can have the best molecule, but you're not going to get the outcomes unless the health systems are fixed. It's like having a bullet train run on a dirt track. And we're getting more and more sophisticated bullet trains running on dirt trucks. Yeah. And that's a real challenge because many of these precision medicines require very sophisticated, not just IT systems, but once patients are stratified, they need to manage along very different pathways. Yeah. So unless this part is fixed, where the 80% of money is in the health in the health sector, we're not going to get the outcomes we want. How do you change the funding model to get funding in this kind of innovation?
I actually think that some of the approaches that NICE has taken, I mean, we generally don't like NICE, but it's actually been quite sensible, which is exactly that, funding for outcomes. So instead of funding all patients with that particular diagnosis where you know only 20% are going to respond, you actually fund patients according to have they respond at 3 months, 6 months, and then you can put the pricing up, and it's better for everybody. You can actually price according to the benefit that those patients are getting. So it's a long way away from what I do, and America has to sort out health economics. I mean,
the other part of the systems that you're referring to, another thing and that we are going to make a big push in this is clearly diagnostics. And you look at what's going on with diagnostics, particularly on the molecular level. Again, great wave of innovation. And I was talking to the CTO of Illumina not long ago, and they've got an in-house. They've developed a company in-house called Grail that they're fundraising for, which is hoping to diagnose cancer at stage 1 and 2. Now, if they succeed, can you imagine what happens? So, if you're getting cancer patients stage 1 and 2, I mean, the cure rates, survival rates, the pressure of this, and if that could be now, the issue goes back to what the panel earlier was saying is, our system is going to be willing to invest in diagnosis today in order to save money later. And sometimes the healthcare systems can be a bit short-sighted, so that's the issue. But we're convinced that diagnosis, better diagnosis, earlier diagnosis, has to be part of the solution, which, again, it's,
one more question. You've been very patient.
Well, it was much on the same path, which is when you look at targeting investments, how much are you looking at the competency of those groups that are going to take that asset through to market and their ability to engage with stakeholders and start those discussions early? And it's interesting because I think we saw yesterday it was announced that Regeneron and Sanofi had started to talk to the PBMs about their new eczema drug, which was considered affordable at $37,000, I think it was, per year. And you know, it speaks to the fact that far earlier on, you need to be engaging with those that are going to assess affordability. And that isn't necessarily a NICE model, which looks at cost effectiveness. This is an affordability model. And I wonder, particularly on your late stage, and for you, Kasim, how do you assess that competency? And how do you know that the people that you're investing in are actually looking at the broader picture?
Yeah. Well, look, I mean, the only way we do it, and I'm glad you raised it, is you're right. It wasn't, you know, when you sort of do the tick the box of whether you're going to invest in something and you look at the capabilities, frankly, commercialization risk was pretty low down the scale, right? We focused on R&D and science and track record of that. And we know today that there are great products coming on the market, you know, at the PCSK9s, Entresto from Novartis. I mean, these are amazing. What have they done? Very little. Why? We don't have time to answer. But so there's a new thing called commercial risk, and I've been banging the drum on that internally in our organization, which is it's not just about the science. Figure out how is this thing going to get to market, how is it going to get sold, how is it going to get priced. And by the way, the selling model is very different today from 5-10 years, et cetera, et cetera. So, great point, great question, and it's just something that we due diligence now, like we, you know, in a way that we didn't do historically.
So, Michele, Kate, Kasim, thanks for a brilliant discussion. That was a really, really insightful discussion. We should just give you a clap. Now, we've had an incredibly full morning, but there does seem to be an outbreak of consensus around certain themes, and I've been taking notes, and I'll be revealing my take on what those themes are later on. We've got lunch now, and then this afternoon we'll be looking at implementation and leadership, but you've also got to earn your lunch. We will give you the lunch first, actually, but you'll be participating in a short breakout session, so you've got to go and do a bit of work as well. But please go away, have a good lunch, do some networking, and we'll see you back here at whatever time it is, 1:55. So I won't have a chance. So let's see here, It's very good. And,
we'll trade information on jewelry making.
Jewelry
First of all,
making,
the most important thing.
somewhere. Here we are. Yes.
And then, to the lesser important things in life, such as healthy people.
Yes, exactly. From in Geneva, I'll come and pick you up. Yes.
I don't I apologize. I didn't really
Okay, everybody.
So I think I'll introduce the afternoon session.
Oh yes, sorry, yes. Yeah. No, actually, I've forgotten to Law introducing the afternoon session. She just reminded me. But I'll do Rebecca. Yeah. Yeah.
What time is it? Shall I start?
I think you just have to shout and get people in. Yes.
Shall I type one more time? Or?
Please.
So thank you very much. Welcome back from the lunch. I'm sorry it was relatively brief, but that's because we have a full and very exciting afternoon. We're going to start with Rebecca Fogg, who's going to tell us all about disruptive innovation. It will be followed by breakout sessions. So the idea is that we will ask you if you can go again outside, and you've all been allocated to a different table, which you can find in your program. And we will engage you in a discussion. We have people to take note. And then we will have Professor Carol Popper, summarizing your thought and giving you her expert views on this different area. Then we will finish the afternoon with two different types of panel. One where we have relatively newer player in the healthcare sector, and then another one where we have strategic and operational experts to tell you about delivery of healthcare and who's going to take the leadership. So now, James, please, I'll let you introduce Rebecca.
Okay. Just want to carry on this theme about disruptive innovation. I think one of the things that's come out this morning on a number of occasions and sort of theme that ripples through the discussions is this idea that certainly med tech and pharma is very, clearly a hugely important part of healthcare in the future. But actually, the real challenge is around business models and the delivery of healthcare services, and the need to rethink how we organise healthcare in a way that is affordable and delivers the best possible quality care. I'm very pleased to have Rebecca Fogg with us today from the Clayton Christensen Institute for Disruptive Innovation. Those of you who know Clayton Christensen's work, goes back 20 years now, and he was instrumental in getting this idea of disruptive innovation lodged in people's minds. And Rebecca's going to talk about what this means in the healthcare sector. Rebecca was, she was educated at Harvard. You're American, and but she lives in London, and one of her hats involved founding the Institute for Pre-Hospital Care at London's Air Ambulance and working with London Air Ambulance to look at their ways of working. And she was also instrumental in developing and running the first undergraduate degree on pre-hospital medicine with Queen Mary University. She comes from a consumer financial services background, and Rebecca, I think over to you to give us an insight into disruptive innovation in relation to healthcare. And I think this will be a great scene setter for the breakout later on. Rebecca.
Thank you very much. Just want to make sure I don't back over that table there. Good afternoon. I'm really delighted to be here to share some insights from our work at the Institute, and I hope that they will inspire your brainstorming in the afternoon and also create a dialogue between us that could help shape our work at the Institute. So, what is disruptive innovation? You have probably noticed that people use the term in a lot of different ways, but it actually has a very specific definition. Disruptive innovation is not the kind of innovation that makes a good product even better. It's the innovation that takes a product that was historically so complex and costly that only a very relatively few people with a lot of money and a lot of skill could access and use it. And it transforms that product into something that is so simple and affordable that a much larger population of people can access and use it. Sounds like something we might need in healthcare, right? So how does that transformation happen? It doesn't require a miracle or particularly a lot of luck. But what's really important to understand is that it's not just about the product. So does anybody recognize this product here? Did anyone ever have it? Can I see you raise your hands? Okay. We have 3 people who know what the iMate Jam is. So the iMate Jam was released in 2004, and it was billed as a pocket PC. 2007. Anybody recognize this product? Anyone ever have one? Who has one right now? Can I see you raise of hands? Right, okay. So this is pictured actually the first generation Apple iPhone. And it is the innovation that essentially created the smartphone category as we know it today. And smartphones are basically the latest wave of disruption in the computer industry. And they have made computing accessible to literally billions of people around the world. And they've made it so simple that pretty much the average 2-year-old can unlock the screen and start live streaming a Peppa Pig video in about the same time it takes Dad to remember his password. And that's disruptive. So that is an incredible phenomenon. And what we want to know when we understand all that is, why was it the iPhone and not the iMate Jam that created that wave of disruption? What was it about the iPhone? They were both cheaper and simpler, and they even had a similar set of features. So the reason, which we'll explain in a minute, is because it's not just about the product. It's about how you use the product to address a need that incumbents are ignoring. And on top of that, it's how you create a business model and wrap it around that product so that it's successful. The applications feature on the iPhone, which you're all familiar with, and actually Android uses similar business model now. The applications feature is a terrific illustration. So Jam users were basically stuck with the small set of applications that came loaded on their phone. On the other hand, Apple created an entire business model around the applications feature that essentially made the product infinitely customizable. And the result was that you have, let me back up a sec. So I'm going to tell you a little bit how they did that. So this was not a simple fix. This wasn't just about coming up with some kind of a pricing mechanism. So on the demand side, on the consumer side, Apple had to create the technology to easily download an application from the web onto the device. They had to create the App Store application. They had already in place a huge network of Apple stores that provided free support at the Genius Bar. All of those things together worked to help consumers want and shop easily for applications. Importantly, then there was also the supply side. So they created an entire community of developers that created this infinite supply of applications. And that also was a very involved situation. So it was developing technical specifications in a development kit so that the developers could develop for that platform. Intellectual property terms, payment terms, a whole host of processes and policies and assets that Apple needed to put in place so that they had this sustainable relationship with developers, sustainable, profitable relationship with developers, so that this product remained customizable. And the result was a digital marketplace with essentially an infinite solution set, and it became the indispensable tool so that people could solve almost any problem wherever they were in the world. And the result is that in late 2015, I think it was, the iPhone actually surpassed PCs in terms of global sales. That's an incredible story. Now, if you crack open the iPhone, you're not going to find developers. You're not going to find IP rules. You're not going to find any of that. That's business model development. It's not product development. Without all of that, it's pretty similar to the iMate Jam. Okay, it's more elegant, it's got swipe, you know, there are some bells and whistles, but it's a much different animal when you wrap that business model around it. That's what made it different. That's what helped it trigger that wave of disruption. So that's the lesson that disruptive innovation teaches us. It's about competing differently. It's not just about the product. It's what do you use that product to accomplish, and how do you align every single part of the business model around that purpose to make sure that it's successful. So how do we compete differently in healthcare to make it more affordable and accessible? And that's to any payer, whether it's the government, whether it's the individual, whether it's an insurer. How do we do that? Same way you do it anywhere else. You need to use your product, your healthcare, to target a need in this circumstance that our existing system is not designed to address. And in healthcare, that need is going to be pretty specific. It's for care that helps individuals live the longest, healthiest lives possible in their particular circumstances. And then you need to create that enabling business model that allows that future to come true. When you do that, when you target that need, and when you create that enabling business model, the reason it's disruptive is because it creates the conditions in which innovation can can reduce the human and the economic burden of massive issues like chronic disease. That's how disruption can make healthcare more affordable. A disruptive solution creates the environment in which that kind of innovation can solve that kind of a problem. So let's apply our framework to an example. Is telemarketing, you know, financial services, it just came back in that one instance. Is telemedicine disruptive? Depends entirely how you use it. If you use it to maximize utilization of your physician network in context of a fee-for-service environment, it's an improvement. It's the same as the existing system, but it doesn't disrupt it. On the other hand, if you use it to make it easier for a system and the consumer to collaborate over the long term in improving that person's individual health, then it could be disruptive. So the answer to any question of is this or that disruptive, it's always going to be it depends. How does it help you compete differently? So leading into a second insight, given all of this, where do we see interesting innovation brewing in healthcare, and particularly interesting in the area of consumer enablement, or as we might say, democratizing medical expertise? HealthTap is a digital platform that helps consumers assess the medical risk of any particular issue that they're experiencing at the first step in the pathway of care. The next company is something called Autism Beyond, and actually it's not commercialized yet. It's part of a Duke Medical Center research project, but what they've done is used Apple Research Kit to create an application that would enable a parent to show a video to their child, and through that process they're able to evaluate the emotional response of the child. And the objective would be earlier autism screening. The third example, in-home hemodialysis, that's actually not the prevailing method in the United States, but it's obviously something that allows a consumer to do something in the more familiar environment, the less expensive environment of their own home than going to a regional center. And then finally, we have Iora Health, which is a primary care practice. The first three innovations, whether they're going to be disruptive or not, it'll depend on the context in which they use them, but they do have the potential to accelerate progress toward that future in the sense that they help consumers get the right care in the right place at the right time, given by the right resource, even if that's them. And by right in all of those circumstances, we mean it is the solution or the option that makes the largest contribution to long-term health for the least necessary cost. I'd like to spend a little bit of time on Iora because I think that's perhaps the most exciting example here in the sense that they've developed their disruptive innovation and they've wrapped a business model around it, and they have some really interesting early results. So Iora is targeting that unmet need of long-term individual health for an entire population. And their disruptive solution is the relationship that they create between the system and the consumer over time. They use health coaches as the primary contact, the owner of that relationship, the owner and the developer of that relationship. And it's a very deep and trusting relationship that essentially allows that the organization leverages to help move the patient along the continuum of self-care. So the entire clinical team supports the health coach, and in fact, it's the clinical team, it's the payment method, it's the technology setup, it's the physical environment. All of that is designed to help the health coach understand what the consumer's world is like and come up with solutions that resolve their barriers to adopting healthy behaviors. That's really, really important in chronic care, and Iora focuses a lot on high needs population. And it's early days, they're only a little over 5 years old, but they're already seeing some really terrific results with some of those high needs populations. Blood pressure and diabetes control metrics are beating national standards by a long shot in some cases. So they have everything in place. We'll see what happens. But it is really inspiring because it shows us what's possible. So when you're thinking about solutions for the future, building that ideal system in the 30 minutes that follow, if you can keep in mind, when you're talking about what would disrupt this industry or what's the innovation that we need, what kind of innovation do we need? Are we solving a different problem than the incumbents? There's a lot of innovation focus around outcomes. Let's design everything to optimize outcomes instead of inputs or maximize transitions. That is certainly an improvement on focusing on transactions alone, but outcomes can still be very short term. And it's a lot of work, and there's a lot of innovation involved in figuring out how actually do we measure long-term health? How do we know where we are on that continuum? Population health management, also not a new idea. Really, really important. A big improvement on fee-for-service, transaction-focused care processes. But again, sometimes population health management can just be managing to the averages. And not one single person in this room is an average person. So, the real solution is it pointed toward the long-term health of an individual in their given circumstances. So are we solving a different problem than the incumbents, and are we solving for the right problem? And then the second question is every element of our business model designed to do so, not just the product. There's a lot of talk about profit model. It's table stakes. Does it reward resolution of that problem? If we are continually making progress toward resolution of that problem, do we have a sustainable operation? And then processes. Do we have processes for improving that product, for shopping, and for using the experience? One misperception can be that put in the right financial incentives, put in the right payment model, and then somehow magically we actually know how to achieve that goal, but the incentive to achieve that goal does not create the capability to achieve that goal. So you've got to focus on care processes. That's part of the business model. And then there's innovative use of resources that keeps costs low. There's a lot of progress we can make there. That's something we understand we need to do. In the case of IORA, the health coaches are doing a fantastic job on something that nobody else needs to do. They can do it at the highest level, and they're less expensive than a physician. And that actually frees the physicians to work on the really tough problems that only they can do. This isn't a new idea, but it's hard to put in place, isn't it? Yeah. Oh, distributors who depend on our success and not our incumbents. So that has big ramifications. So it's about how do you make money, what makes your organization financially sustainable. If the organization you are dependent on to use your product, to prescribe your product, to market the product, if they're not making money the same way, there's going to be a disconnect. And that was a theme throughout. It's about aligned incentives. So it's thinking about, who else has to benefit from this solution for us to be sustainable. So I hope that those are some brief thoughts and some ideas that will shape your thinking, not just in the next session, but over time. And I would really enjoy hearing from you, your thoughts about the session and how it applies to your work. Thank you.
Time for one quick question, perhaps, before we move on. Anybody? Yeah. Kai.
Not a question, a comment. I think it's really interesting in the Apple iPhone case that nested in there, I think, is another disruptive innovation story in the sense of graphic user interface.
Talking about this.
Okay.
Which I think was the predecessor of the whole Apple concept.
Just introduce it.
As far as I remember, that was developed in Palo Alto Research Park.
Do you mean the menu-driven?
Yeah, the user interface, which then of course kicked off Apple.
Yeah, that's the famous story, right?
So within there is another disruptive innovation. Just a comment. Sorry.
Yeah, no, thank you. And the camera, another example, right? So it started out, it was kind of a not so great camera, and now there are professional quality photos coming out of this. So you can think of it as there are many business models wrapped around that product. Thank you.
Good. Okay. Well, that's definitely food for thought. So now is the time for you to earn your lunch, which we've already provided you with, including the two macaroons.
Those are mine.
You should have. You've been allocated tables. I guess this is somewhere in your pack of information. So if you could make your way to your tables, and there should be a sheet with 3 questions on it, okay? And as well as the 3 questions, actually, we want you to have a little think about the solutions as well, because we realize that the questions are all about the challenges, and we actually need to think about some solutions as well. And we'll come back here, and Carol Proper will be endeavoring to draw some conclusions. So off you go, and then come back.
very much. We have a microphone that don't work. Thank you very much. So thank you very much for your ideas, your suggestions, very interesting discussion. We've seen very active group around. So thank you very much for your contribution. Carol will summarize your different points, and I'm thrilled to introduce Professor Carol Popper to you. She's an outstanding economist. She has received in 2010 a CBE for her services to social science. Carol, throughout her career, had a long interest on how to improve the delivery of public services, including healthcare. Carol's research interests include the use of market mechanisms and incentives to improve healthcare delivery. She has also done work on the impact of environment on health, just to name a few. Carol has been at Imperial since 2007. She was initially the head of our health group. She is now the Associate Dean for Faculty and Research. Her previous role have included, and I just name a few, being chair of the Economics and Social Research Council Grant Board and member of the ESRC Council. She was the advisor to the chief executive of the NHS and a member of the UK Research Assessment Panel in one of the previous rounds of the UK government assessment of the quality of UK university. She has done a lot of things. You can see it all online and in our brochure. Thank you, Carol, for your contribution.
I'm very pleased to be here in the sense that I've been going around the tables and I've really enjoyed the whole day. And also going around the tables, I've just been impressed by the set of ideas and the rate of ideas. It's always really difficult, I think, in these breakout sessions to kind of know where to start other than kind of iterating what we all know. And then, you know, I think you guys have really worked for your lunch that you already had. So I kind of wanted to, that what's been happening has been scrolling through, so I've been listening and watching. And I wanted to start with, I think, trying to summarize a kind of key set of issues that kind of came up everywhere. And the first was and we've heard it during the day, a general reflection of the rigidity of the system. Whichever bit of the system any of the tables were talking about, you were talking about barriers and misaligned incentives, whether they be KPIs not linking to payment systems, whether they be the kind of problems that we were hearing about this morning, about trying to get new, radical, cost-effective ideas into a system in which one payer wouldn't want to pay for them and another one had money. So the whole idea of rigidity, misalignment of incentives, and interestingly, this is not just on the supply side, but also on users. So it's basically, somebody said very nicely that there's a whole issue around expectations and attitudes. And I think a really good example is 30% of the population are obese or overweight. A large proportion of the population have diabetes. And they implicitly expect a kind of 1950s model where that is solved by somebody else. So quite a few tables were reflecting. And of course, you're worried about social expectations. If you grow up in an environment where 50% of your friends are overweight, you're not likely to judge being overweight as a problem for you at 13, 14, or 15. So there's a whole pile of social expectations, rigidities on the user side as well that I think many tables were bringing up in different ways. And we haven't heard too much about today, but it's also obviously important when you're thinking about things like disruptive innovation that's going to involve users. I think clearly the politics of systems matters. All healthcare systems have large public sector involvement compared to many other markets. And that came out in many people's thoughts and discussions. And I think somebody also reflected that we have many systems that are designed to pick up the pieces. We need a set of very complete kind of reforms. We at the moment have a system that essentially institutionalizes bad health, rewards providers for essentially treating bad health, and in some ways doesn't challenge users and consumers about having bad health. And I think a lot of those things are kind of going forward. And finally, we're doing all this in a very politicized environment in which the timescale of politicians, unless you're in Singapore and have been building this since Lee Kuan Yew in 1963, or China, The timescale of politicians is short. They're always looking for the next buck tomorrow rather than in several years, and many of these things take a while. So I think we're all very familiar with that kind of catalogue of issues, and the tables reflected the nice divergence, the kind of almost the 360 on this. So kind of I now want to move to kind of what kind of solutions that people were talking about. And I think here there was much more mixture because people were talking about particular systems and often reflecting on solutions that were appropriate for those systems. But I think I want to again draw out kind of what I think was the sort of top line issues. The first was, and I think this is a very obvious one, and it came up very much in Rebecca's talk, which is we need a empowering, in the jargon of healthcare systems, you'd call it empowering patients. We need to have a system that is designed around the needs of the users of the system. If you move into more market areas, you'd think about this as consumer focus. So we need a general kind of rethink away from, if you like, a provider, an industry focus, to a consumer focus. And I think one of the tables, interestingly, reflected that this is not necessarily at all just a problem of the healthcare system, that it's a problem that affects many, for example, middle-level FTSE companies, that they're very much around the role of the provider rather than the role of the user. And that's very much what we saw in Rebecca's talk about Apple actually focusing on what a 2-year-old might want out of, or a 2-year-old's dad might want out of their mobile phone. So the first thing I think that everyone agreed on was whether they called it consumer focus or empowering patients. Secondly, within that, we need acceptance of, and this is, I think, very important, better use of data and resources. So whilst we'll all agree that there's masses of big data out there, that's what most of my work is about, for example, there's lots of challenges to use of this data. And there were some tables that reflected that that might be changing for the better, in that what 30-year-old and under 30-year-old actually cares about their privacy. They know that anyone can hack into anything. On the other hand, the 65-year-olds, who are mainly the users of systems, are still very unknowing about data and very fussy about how their data is being used. You can see it within the NHS already. People are opting out of the big data systems that we have on them. So there's a need to use data both by providers and involve users in using that data and using their own data and becoming aware of using those data. The third thing was that, and I think this reflects many tables, issues around strong leadership and clear vision. And I think that echoes something that's been said a lot today that underlies a lot of things. There is a need for leadership here, whether we call it governance, whether we call it leadership of the firms that are on the provider side of the market. There's a need for people to take that leadership role, and I think that's a talent that's in very much short supply, and possibly is very much in short supply in very politicized healthcare systems, where basically what leaders do is play to politics rather than actually leading their organizations. So that was one very clear message that came out, that we need to enable leadership. We need to be able to take that clear vision. And finally, I think, or two more things, and around that, there was ideas of discovery-driven adoption of innovation, that we want things like trials and things. I think I'm mixed about trials, and I think there are issues about using trials, but there's certainly an idea behind that we want experimentation, we want innovation. One size does not fit all. When all is the patient, no patient is an average. And finally, I think a very interesting idea that came out is the current system is essentially designed to pick up the pieces and in some ways has no attitude towards risk. And what quite a few tables were kind of reflecting is there's a need for risk sharing. We've heard about models of risk sharing on the provider side, that you're taking risk sharing when you're a venture capital. You're risk sharing with the producers of new ideas. So there's definitely a need for different models of funding, which essentially are about different models of risk sharing. But there's also a need for risk sharing with patients. We may be thinking about new models of care in which we expose patients possibly to more risk in order to give them incentives to take better care of their health. A nice example would be some of Singapore's, you save for your own health and you help poor people save for your own health. But in a sense, you're pushing some of that risk back onto people in the idea that that will give them incentives to look after their health better and to adopt what's being offered by the system. So I think there's a general need to look at the kind of risk models that we have, if you like, both financial risk and other risk models in this space. So I think those were really fascinating ideas that all came from the tables, and I hope that gives you kind of some flavor of the people who haven't talked in the discussion and some flavor of it. What was very much a kind of consensus, I think, set of ideas. So thank you.
So our next panel, Franco. So I'm delighted to introduce Professor Franco Sassi. He's an expert in the economics analysis of public health policies. His work has focused in recent years on chronic disease and their social and behavioral determinants. His work includes obesity, nutrition, physical activity, alcohol, and tobacco use. He has made numerous contributions to the research, including 2 books, The Economics of Prevention and Obesity, and another book on the economics of alcohol use and public health policy. Franco only joined Imperial in 2016 and has a chair in international health policy and economics. He's a director of our new center in health economics and policy innovation. Franco is also a senior health economics at the OECD in Paris, where he has established the OECD public health program. Thank you, Franco, for being here.
Thank you, Laura. Thank you very much. That's a very kind introduction, but this session is not really about me or my work. We have 2 business leaders, Wendy Belluomini and Frank Lehman, who I invite to join me on the stage. So the session is about them, what they've been doing, and about their organizations, which are 2 key actors in their respective sectors. I'm talking about IBM and Nestle. Clearly IBM in this field of IT solutions and Nestle in the field of nutrition and food. We are going to talk about how they've been driving innovation in the healthcare sector, which is something that clearly fits in very well with the discussion that we had so far during the conference. We have heard about the major challenges that healthcare systems are facing. We heard about aging, we've heard about lifestyles, we've heard about the potential shocks that might threat the system, like antimicrobial resistance. We know now that innovation is lagging in the healthcare sector, and we don't have enough innovation, and often when we have innovation, it's not of the right kind. So there is a desperate need for disruptive innovation, and actors like IBM and Nestle have been playing that role in the past few years and have the potential to change the landscape of healthcare innovation in the future. So let me start with Wendy. Wendy Belluomini is based in Ireland. She's the director of IBM Research Ireland. She has been leading the efforts of IBM in cognitive healthcare management. I hope she would explain what it means exactly during the talk, and health data privacy. And she's also the person behind IBM's strategy for brain-inspired computing, which is also something that we might need some explanation about. So over to you, Wendy. I mean, how as IBM entered the healthcare field, and what kind of innovation have you been producing?
Okay, let me start with the story of how we ended up in the healthcare business. IBM made a big impression on the world, I think, in 2011 with the Watson game show, win that we went out and said, okay, we can get a machine to answer questions in an open domain in a way that's competitive with the best humans that are able to do. That was 2011. And that was exciting, but that was certainly not a business. That was a very nice public relations awareness kind of thing. So once that happened and we felt, the company felt like it had this ability to learn from data at scale, answer questions in a complex open domain, in some sense there was a search for, okay, what should we go do with that? And there were many things that were talked about, but the company really settled on healthcare as the place where we were going to make the biggest investment in bringing AI technologies to the marketplace, and where we thought that there was the biggest transformational potential because the data was complex, there was a lot of it. People had kind of, I mean, we weren't the only people in that space, obviously, but we had not seen that transformation in that space that we thought was possible with data and machine learning. So between 2011 and 2014, when the Watson Health unit began, so we've only really been in this business for about 3 years, we went from almost nothing in a business sense. I come from IBM Research, so one of the things that we were able to do is leverage bits of science that we had in IBM Research. So interestingly, IBM Research will do work in areas that we're not in that business. We recently launched a product through Watson Health around a radiology assistant. So this is something that uses machine learning based on large amounts of data to identify stenosis in heart disease, while also utilizing other things like medical notes, background about the patient. The person who built that had been working at IBM Research on that problem for some 12, 15 years before IBM was in that business. Our genomics work is similar, so we have Watson for Genomics, that's now a product. The scientists that built the underlying science for that product had been working on that in IBM Research for some 10 or 15 years. So one of the reasons why we were able to create this health business is that we, as a company, invest in science continually, even if we're not in that business. So IBM Research has some 3,000 scientists around the world that are building these seeds that might become IBM businesses later. So anyway, that was a bit of a digression, but we went from nothing in 2011 to the launch of IBM Watson Health in 2014. It's now 2017. We have some 7,000 people working in healthcare, some 300 million medical records, and 30 billion images that we have acquired through a set of acquisitions. In addition to then we took that, and then we took the science that has been developed in IBM Research over the past 10 or 15 years, and now we have created what we think is a transformational capability around AI and machine learning plus large-scale data.
Who are your partners in this? Clearly you
so for any of these things, we have to have partners. So for Watson for Oncology, for example, we trained that system with the doctors at Memorial Sloan Kettering in New York. We have work around predicting adverse drug interactions, predicting and tracking. When a drug is out in the marketplace, is it likely to have an adverse reaction with this patient? We're partnering with a company called Celgene in the US that does that. So we have a large consortium of around 24 providers and radiology groups around our radiology assistant that are bringing both data and expertise around how do you train these systems. So yeah, that's a key thing, that anything that IBM does in the health space is in partnership with clinicians and with other companies that have that deep 100-year history in many cases developing and providing care in that space.
That's excellent. I mean, we come back to this because this conversation is really as much about what your companies are doing as how you're doing it and how you're achieving you're pursuing leadership in innovation in healthcare, so that will be very interesting to find out more about. Frank. Frank is Vice President of Nestle, and he's head of open innovation and venturing at Nestle. He wears different hats within the company, and one of the things he's been doing is leading the health innovation, the innovation acceleration team within Nestle. Nestle clearly comes into the healthcare field from a completely different perspective from IBM. Your background is food and nutrition. So what has driven Nestle within the healthcare sector?
Okay, so thanks. Maybe let me put this also into perspective. I mean, we have heard a lot about what puts the pressure on the healthcare system overall. It's the demographics. It's in principle the aging aspect. I mean, we will see some numbers have been shared, but I saw another number, for example, that in the developed countries, in around 2050, we will have 70% of the people will be above 50. Now, everybody who is above 50 can ask, are you already aging or not? So you may say you're still fit, but you feel already not like 20 anymore. So that's one thing. Then obesity is another topic. I mean, we have one out of 3 people are already either overweight or obese. 20% of the children in China start to have significantly weight issues. So that's, of course, is one thing. But subsequently, which was also said before, is the additional diseases which come with the whole thing, like diabetes type 2. So we've been, from a heritage point of view, over years, of course, of 150 years in the field of nutrition and health. So the thinking was always, and we saw this in the early 2000s and 90s, that we saw investments, we saw more and more technologies coming into the nutritional sector, where people started to try to not to cure diseases, but to prevent specific actions through nutritional intervention. And I want to give one simple logic. I mean, we all know how much a diabetic patient type 2 will cost per year the healthcare system. Just assume you have somebody who is obese, who will not probably slim anymore, who comes into this. You can just prolong the fact that he moves into the insulin treatment by 1 or 2 years through a more adapted nutritional intervention. You save a lot of money for the healthcare system. So that was the starting point of our idea when we said, look, let's set up Nestle Health Science in principle. What can we do through nutritional intervention? Not to cure, but to prevent diseases or to prevent metabolic disorders, to ensure we move forward. And you can take that when it comes to, I mean, technologies are developed and looked into this when it comes to cognitive decline, Alzheimer, with respect to ketone body diets, any kind of different technologies we looked at. We heard before, of course, the microbiome, which we don't understand at all, but we can start to modulate it and will have an impact on a lot of things of the lifestyle, mood, for mood, but also curing how do you feel. And we see this, of course, when it comes to all kind of metabolic issues like diabetes. So that was the starting point, and we believe that that is one way forward, and you can, in principle, bring things into that right sector. I also want to say one more thing, and you see the people who are in the venture industry probably see this already, that nutrition is an emerging science. I mean, 10 years ago, we would have seen difficulties to have hardcore pharmaceutical approaches or biochemistries to work on nutritional topics. Today, we see more and more money flowing in. We see more and more investments into the nutritional space. So we see that there is a huge opportunity where new technologies will provide solutions in order, what I said before, to cure things. And we strongly believe it's not about, I mean, at the end, we all age. It's just to add good lives to your life, to just postpone also the issue. And also, when topics come up like, we hear a lot about fighting obesity. I think it's all more about preventing obesity or reducing the weight
growth over time, because we should not be naive. At the end, I mean, the fact that this happens has to do with the lifestyle, has to do with the way of how we move forward. And that also is one of the ideas we believe. It's, at the end, in order to do this from a nutritional point of view, it's just not a pure one single molecule solution. It's a combination of a nutritional intervention, a diet, maybe an advice, maybe a service. So at the end, it's a mindset change. It's a consumer behavior change. It's an individual consumer behavior change which we do. And that comes back why we believe as Nestle we are very strong, because we are the brand owners, we are the first entry point to the consumer. I think we can, in principle, build that relationship with the consumer to build up.
You're raising an excellent point, among others, that innovation can actually help healthcare systems become more sustainable. And when I was saying in my introduction that we don't always have the right type of innovation in healthcare, I was meaning precisely that we've been great at producing innovation that has enhanced the capabilities of medicine and healthcare systems, so we've been much less good in terms of producing innovation that makes healthcare systems sustainable and increase productivity in the healthcare system. So what makes you confident, and that's really a question for both of you, what makes you confident that the type of innovation that you're working on will actually make healthcare systems more sustainable? Wendy, would you like to start?
Yeah, I think the kinds of innovations that we're working on, when you really boil it down, are there to help make the individual people in the healthcare system more productive. So for example, with something like a radiology assistant, you're trying to make that radiologist find the image that she needs to look at in 2 minutes instead of in 10 minutes. From a healthcare sustainability point of view, that means that you don't need as many radiologists per patient. Because in the end, most of the costs in our healthcare systems come from how many people do we need to provide care at a certain level of quality. And so most of the innovations that we're working on, whether it's something like the radiology assistant or some of the things that we're building in Dublin around care management, which is a product where if you have a person who's in charge, like the health coach that was talked about earlier, who's basically in charge of managing a person's care, we're creating a set of tools to make that person more efficient, to learn from the previous patient that they talked to that looked like that and say, okay, you have a patient that looks like this profile, here's the set of recommendations that you probably want to give to this person, here's the set of services that you probably want to recommend for this person, and here's how that individual can access those services efficiently without that patient having to go do this planning task before they go and do the health task. I mean, talking about compliance and getting people to take on healthy behaviors, it's hard enough to get people to take on healthy behaviors without having to add a planning task in front of it. So we're building systems that will do that planning task for you, who then work in concert with someone like a health coach that will have a personal relationship with the patient so that the patient can then go take on those healthy behaviors with hopefully higher probability.
Behavioral economics, we call it commitment devices.
There you go, commitment devices, yeah. Yeah, actually, I don't think it's quite that, because I have not seen a thing where it actually gives somebody the hard incentive to do it. What we're trying to do, and maybe that's a good idea, but what we're trying to do is just kind of at least remove some of the barriers. Well, they told me to go take a exercise class, but the only one I know of is at a time that I can't really go, and so, I won't do that. Instead, we know your schedule. There's an exercise class here. There's public transportation that will get you there at this time, and we have, provisionally signed you up.
I can see an episode of Black Mirror.
Frank, do you have any further thoughts about sustainability?
Yeah, I mean, of course, I mean, we are in nutrition, we are selling food, so a bit of this simple thing, an apple a day keeps the doctor away. So if you're more healthy, you hopefully see the doctor a bit less. Therefore, you should have less pressure on the healthcare system. But make this a bit more serious. I mean, we are not only selling products in the developed world, we are selling a lot of products in the developing world where we fortify products with iron, with zinc, with vitamin A, where you have significant needs. And people in these salary classes and who are in no healthcare system, and they buy our products because they cannot afford to be a day sick, because a day being sick means a day less of salary. So they need to stand. So they are looking for the right nutrition. Now, that is the developing countries, but I think we are moving into a similar concept in the developed countries as well, as the healthcare system may become more and more expensive. So there needs to be ensuring you live a more healthy life and you can be supported. That's, I think, our approach can be quite helpful. Now, having raised that, of course, on one stage, there is a challenge when it comes to regulations. So how do the regulatory system we are today facing may not be suited if we long-term believe that nutrition can play a significant role to fight against the issues in the healthcare system. So also there needs to be adaptations. What are the claims you can do? What do you need to provide to do the claims? And this is not a secret, but of course, as a food company, you never have the same means to run the same trials as a pharma company. So you need to think through in which are the areas where you allow a different approach, or where you need to have a different approach of proving the efficacy of your nutritional intervention, for example.
To follow up on this, Frank, I've asked Wendy the question about partnerships. So clearly, following up on what you just said, Nestlé as a major player, international player in the food sector, is under a lot of pressure from governments and public health agencies to work with them on addressing the issues to do with the obesity epidemic. So can you give us an example, one or more, of a constructive relationship that we have built with individual governments or public health agencies to address this problem?
I think we are working at the end. I mean, we've been several times under discussion about what are we doing and how should we move that forward. We are working more with respect, let's say, with public-private partnerships with the academics to find specific solutions, technologies in order to bring that forward. I think that is something definitely where we move forward. We have also worked, of course, with governmental institutions on several aspects when it comes to regulations, also when it comes, for example, to the WHO code, when it comes to infant formula feeding. So we are in principle working in partnerships in order to bring that forward. But I think the key part, because you asked about the partners, if you really want to innovate in that field, then you have to, then you need to work with different sets of academics and industry partners in really to put forces together to find the next level of technologies. Because that is what it brings forward. As I said before, nutrition is an emerging technology. I think we cannot simplify the solution at one stage. I mean, also today when the food industry is under attack of governmental issues with respect to the obesity, one thing we should not forget, the food industry is a very diversified industry. So we are a large company, but we have a very small percentage of the market share. I mean, you just need to go through London today and you think how much of your caloric intake is actually through packaged goods and how much you pick up in a pret-a-manger or in an out-of-home food. So I think it's an overall solution as an industry body as well as a governmental intervention of where you bring these two elements together in order to find that solution. I mean, we are very open in order to bring better nutrition and more effective nutrition to the consumer, and knowing that our products have to require the necessary nutritional requirements.
Yeah, I mean, from what you say, I gauge that clearly there is still a barrier that needs to, come down between government and business. I mean, you may, still have a small share of the global market, food market, but you are a major player, and of course, you are in a position to set the standards in your sector. So clearly, there's a lot to gain from direct collaboration with governments,
Yeah.
I think. Let me just touch upon, before I open it up to questions from the floor, touch upon the global dimension of your work. We had previous conversations in which you explained that clearly IBM is a major international global player, has an interest in spreading the kind of innovation that you're working on to low-income countries as well. Can you perhaps comment a little bit on this?
So I think the kinds of cognitive technologies that Watson Health is building really have the opportunity to bring a level of quality of care into the developing world that may not be possible for many years otherwise. One of the things we discovered when we started working in assistance for oncologists that was when we had first built this system, and we took it to talk to our Tier 1 teaching hospitals in the United States, the Stanfords, the Harvard Medical Schools of the world. They kind of looked at it and they said, "Yeah, we can do that. We have the top tier oncologists in the world. They don't need help." And so then there was a bit of rethinking and said, "Okay, that makes sense. Where does the world need help?" So then we started thinking about, okay, we should go to places like India where we're starting to roll this out, where there's something like 1 oncologist for every 1,000 people, or it's not probably quite right, but something on that order, or in China where, yes, humans can, and the top oncologists can do this just as good as any kind of AI-trained tool, but in many places, you're not going to have a top-tier oncologist that is available to most of the population. So can we give assistance to someone more on a general practitioner level that can provide almost top-tier oncology to someone who would have never gotten to see an oncologist before? And so we have work rolling out in India and in China in certain hospitals trying this out to bring kind of the level of care that people expect at a top-tier medical center to people that are at more of a regional level in the developing world.
Thank you, Wendy. Any thoughts from you, Frank, on this? On the way in which you can spread the innovation that you've been talking about to the developing world?
Well, I mean, in principle, we are selling we are selling all over the place. So therefore, the innovation will flow dedicated to the different consumer needs. I mean, we are producing. I think we are in over 90 markets. We have over 450 factories. So that's not for us the issue to bring it at the end. I think that the question is more to get, depending on where you are, to have, let's say, more an affordable approach, of course, for the developing world than you have it in the developed world, because you, of course, need to live with the economic situation in the different countries. But you also see, I mean, that when we speak about the developing world, I mean, even if you take India and China and you look at the middle class, how big these classes are compared, and we have already tremendously huge markets. No, I think we've been in these countries already for a long time, and we will continue off on the franchise of what we are doing there to bring these nutritional interventions to the consumers. Yeah.
Thank you. So shall we open it up for questions from the audience? You have Ian Smith. Yeah.
I go first. So, thank you very much for the. Can you hear me?
Yes.
Yeah.
If you can introduce yourself.
Really, really interesting.
Would you mind introducing yourself?
Yes. So my name is Francesca Rubulotta. I'm here as an executive MBA, but in real life I work for Imperial College and I deal with obesity. Actually, Imperial College as a center of excellence at St. Mary Hospital. So I was curious because lots of these examples that have been brought into the panel come from the United States, where we have essentially private healthcare. And so you don't deal with lots of the challenges of combining private and public healthcare. So we struggle sometimes in bringing prevention and treatment of obesity as a priority. And this means that we struggle to have beds for operating on this patient compared to oncology patients. We struggle to prescribe medication. For instance, we are now having problem in prescribing vitamin D, for instance, which is commonly low in this kind of patients. How can we address? Do you see space for integration between private and public, and how can we improve prevention against treatment of disease when it's too late?
Probably a question for Frank, maybe.
Yes, I think, of course, depending where you are, I mean, fortification of food is one of an easy way to improve the health status along the lines. I mean, I'm not aware of the subscription issue with vitamin D, but of course, you can think through how you fortify in specific elements these things. I think also, and that was my comment on the regulation point of view, of course, nutrition at the moment, nutritional intervention is still coming up. So we are not yet there that, for example, you have a reimbursement model for nutritional intervention. The moment you would see this, maybe the reimbursement model would save a lot of money on the long term because you can bring this forward. I mean, that's in principle our vision, how some of these elements could work, and we could bring more of these emerging technologies on the nutritional side or the emerging science on the nutritional side to the consumers and to the patients. Yeah.
Smith, Four Seasons Healthcare. We talked in the last session about the system and constraints to improving health outcomes, and we'll talk about it in the next session as well. But from your point of view, it's clear that AI on the one hand and nutrition and consumer behaviour on the other are very important. What do you find as the biggest frustrations as you try to take those to market? And what would you do if you were in charge? To change the system so it was easier for us to take advantage of what you both do?
I'll start. I think for AI, the biggest barrier to adoption is data. Right? In order for AI to function at all, you have to have fairly large training sets, and those training sets need to be representative of the population that you're planning to treat. IBM made a number of acquisitions partly to develop our own data sets. But that's not enough, just what we have. And so I think coming up with mechanisms that both allow everyone to get the appropriate value out of their data, that protect people's privacy, because at least for the population that's currently mostly under treatment, people do really care about that. But yet allow the researchers and the developers to have access to good representative training sets for building the AI that they're trying to build is probably the biggest barrier. And that's a lot of working through legal contracts and usage rights and all of these things, which is not technical in the computer science sense at all, right? But we have to get that right if we're going to really see the potential.
I think what we see is more an opportunity than a frustration. I think with the fact that you move into electronic data, patient files, you're starting to collect more and more samples, for example, here in the UK. That big data element will allow us to find more or better nutritional intervention. So that's for us is definitely a big opportunity. Of course, I mean, changing consumer behavior, that's when you're a marketing company, you know that. I mean, working against a trend is extremely complicated and it costs you a lot of money. So I think you need to, in principle, understand the trend. And I think here with big data, with the collection, with also what IBM is doing and providing on tools and systems, that becomes extremely interesting in order to bring this forward. I think as I said before, it's probably the thing where we feel things have to do is that nutrition needs to be, or nutritional intervention needs to have a better regulatory body. I think when you look at the regulatory regime which you have today, you can either go through the food regulation, you go through the pharma regulation when it comes, and then you may have medical food for medical purposes. But that is, I don't think, sufficient enough if you really want to change in the future something.
James, do we have a microphone here?
So, Wendy, this is really a question for you, and it's about some of the work that we've been involved with at WHO in looking at the future of healthcare in terms of the future of the health worker. And this is also, I think, related to what Professor Nicholas, you know, the health worker, our token clinician here, the little grenade he threw this morning about, you know, the 80% of the delivery, the service delivery, versus the 20% that is really what you could call a pure technology innovation. So the way we've been thinking about it, I want you to challenge this if you think I've got it wrong.
Okay.
The way we've been thinking about this is that the health worker is not going to be replaced by a machine, but the machine will be like a multiplier, force multiplier for the health worker.
No, that's exactly our strategy, right? I think the health worker is not going to be replaced by a machine, but that same health worker is going to have to treat 2 or 3 times the patients that they treat now with our aging population. And as middle classes want access to high quality care in developing countries, you know, there's not going to be enough health workers to have the same kind of ratios as we do before. So we don't expect to be able to replace health workers. We do expect to be able to make them both more effective, hopefully, and more productive. Yeah.
Maybe just to build on that. I think with AI and with analytics, we will not need as many health workers. In fact, we'll need different kinds of health workers. Actually, that's very important. And this is something that we've not got right. In many countries, unfortunately, laws governing health professionals go back to 1940s, 1930s, 1920s. It's very difficult to change their roles and responsibilities. It requires not just a change in directive within a health ministry, it changes legal change in the law in relation to the public sector as a whole. So very difficult to achieve, especially in countries that have sort of bicameral systems. But my comment was in relation to data. It's quite late in the day, so let me tell you a real story to make you laugh, I hope. I know telling jokes is very risky. So this is a country where, which will remain nameless, where they introduced a big data system. The whole country was covered with electronic health records. But when everybody logged on, what happened, do you think? System crashed. So what they did, so health workers were using paper to take notes. Then in the evening, somebody would enter the data into the system. So I don't think data is the problem, actually. There are many data around. The problem is analytics, getting the right information, right intelligence to the right people at the right time. If we can get that right, and I think we can really transform this, I think what Nick Peters talked about, this pathway, managing the care process, because there's so much inefficiency in the steps that we take from getting to get from A to B, we go to A to Z, then work backwards.
Well, it's getting the data to the analytics, right? It's getting the data to the analytics. There's lots of data in EMRs all over the place, right? But it's getting that data, you know, fed into the analytics to then produce an insight that's missing. And I'll tell a story as well. So I went to the doctor, and my doctor said, and I said, she asked what I did, and I said, work for IBM. I hate IT companies, she said, because she used to be able to go out with her friends on Thursday nights, but now because of the requirement to put everything into EMRs, she spends her Thursday night and Friday night sitting there copying her notes into EMRs. So this is the, not taking into account the workflow, right? We've gone and we've kind of added another task to a provider that didn't have any time.
The same company.
I think we have time for those 2 questions before we close.
Nick Peters, that was an interesting little story. Did you say she hates your company?
Not my company in particular, just IT companies and computers in general.
Okay, so just to be a little bit provocative, it sounds to me like IBM is a big company that is throwing lots of money at a solution that's going to be looking for a problem. To what extent have you looked at the problems that need addressing and are tailoring the solutions to the articulated problems?
So it depends on the thing. So we don't have one solution. We have a number of different solutions. I think in the care management space, which is what the Ireland team is working on, we work very directly with care management companies that are coming to us with, yeah, this is a problem. And so I think that we are solving a problem that people care about because our customers tell us that we are.
Well, care management is already 3-4 tiers away from the coalface.
From the what?
From the coalface.
The clinical.
Oh,
the clinical coalface. And the story you
Yeah,
told
right,
was
right,
from
right.
somebody at the coalface.
Yeah.
Which is driving her crazy.
Yeah. So can I say that we're addressing this perfectly and we're working directly at the coalface in every instance? Not necessarily. But I don't think any company is.
Well, I don't think care management companies are exactly at the coalface.
No.
I mean, patients and deliverers of care, care workers, I think is Jeremy's phrase.
Right, so I'll talk about a different thing. So like I said, there's a lot of different things. One of the things that we have put together is around, and talking about type 2 diabetes, is around the ability to predict when someone is going to have a hypoglycemic event 2 to 3 hours ahead of when that's going to happen. So in that case, I think that's a real problem. Patients say this is a real problem. And so what we provide is actually an app directly to the patient who's trying to deal with this issue that they can use that will tell them, based on your history of what you've been eating and what you've measured, you're very likely to have a hypoglycemic event. This is what you need to go do. I think something like that is much closer to the coalface than care management.
Just one last question.
Sarah Hayward from MedCity. I wondered whether both of you could say a little bit about how you work with SMEs, if indeed you do, and Frank, specifically the extent to which Nestlé is moving away from its traditional approach in terms of foods and looking at other products that sit alongside your traditional market, perhaps digital technologies.
So we have, in principle, different approaches to tackle the open innovation space, especially when it comes to SME. So either we take minority stakes or we acquire these. But for us, which is a much more important way, is actually a licensing deal. So we have quite a lot of small, very unique companies with a specific technology who develop for us in a specific segment a specific new product or service, which we then can use for a period of time, exclusive, and then we do this. So we are extremely relying on these, also on this small startup scene, on the SMEs, who bring the more innovative technologies. Now, what is the challenge for any SME to come into a large, huge corporate, and that's probably not Nestlé specific, is in order to have a business which is then relevant for us, you need to have a specific size. So take this, you want to jump on an outgoing train, you rather speed up, so else you miss the train. So that's the thing. So what we are looking for is really nurturing this in one of the venture funds to a size, so then the company can be easily taken up and is equivalent to what our internal business activities have. There's nothing worse than having a very small company with a very exciting future business plan, still costing a lot, and a business manager who has to choose between his existing business, which he understands, and someone we take in. So often we come relatively late then actually, let's say, capturing and taking most of the SMEs. But for SME, we have a lot of SMEs who are really service or solution providers along the lines. And especially when it comes to a space outside of the classical food, and that was the second part of your question, when it comes to digital health or whatever, of course we capture very carefully what is happening, and we are very interested in what's happening and what could be relevant for our product solutions at the end.
Thank you. Wendy, would you like to comment briefly on the IBM's model of open innovation as well?
Yeah, so as I said, I think almost everything that we do in this space is through partners or with partners in some way. I mean, from an SME perspective in particular, I mean, we partner with a number of, I would say, medium enterprises who are care groups, hospital groups, doctor groups. This is covering maybe a sub-region of a state to come in and bring one of the Watson Health technologies to them. And as we're developing new technologies, these are usually in partnership with either a large pharma company, a large hospital group, these kinds of things, to bring that clinical knowledge together with the AI knowledge that we have to build something.
Thank you. So I would like to thank Frank and Wendy for a great session. I mean, clearly we have learned that there is a huge potential for innovation from actors that are not traditionally part of the healthcare sector, but clearly there are also major barriers that need to be overcome for this innovation to really make a difference in healthcare. And we've learned that it's not technical barriers, it's more legal, bureaucratic, and possibly political barriers. And that's everyone's business here to bring those barriers down. Thank you.
Thank you.
Okay, right. Well, we're almost at the end, and it's been an immensely rich discussion, and we never have enough time for these things. We have one more panel, though, and Nick Peters threw out that grenade this morning, which Jeremy mentioned just now, about challenging us to think about paradigm shift around the area where 80% of the cost actually resides. In other words, delivery, organizational issues, the archaic structures that Rifat mentioned. And we're really going to turn to that, I think, in our final session. So where's Gabrielle gone? I've lost her. Okay. Oh, she's being mic'd up. We need to get you mic'd up. But let me just introduce our facilitator and whilst she's being mic'd up. Gabrielle Silva works for Brunswick, a global advisory firm focusing on business critical communications, and she leads the healthcare practice for Brunswick. And she's a physician by training and worked in the pharmaceutical industry for 10 years, and then 5 years at GE Healthcare, working on digital capabilities and the relationship between digital and hardware capabilities in GE. So, Gabrielle, I'm going to leave it to you to introduce our fellow. We have, is it 1:45? About 1:45, yeah, roughly.
Okay, great.
Yeah, okay.
Thank
Gabrielle,
you very
over
much,
to you.
and I appreciate this is the last session, so I will try to keep the time. I see slight fatigue, not because it hasn't been very interesting, but there's just been a lot to discuss today. There are a couple of key areas that I don't think we've talked about in any depth, and I'm hoping that this panel, this very esteemed group of people will be able to focus us in on. And those are two key areas. One is leadership. What are the leadership capabilities that are going to take us into these new models of care and deliver a sustainable future, and the characteristics of that leadership? And the second area that I think is hugely important is integration of social care and healthcare. We've talked very clearly around the health delivery aspects, but we all know, and particularly if you're at all aware of what's going on in the UK environment at the moment, the absolute crisis that has hit both social care and the healthcare sector means that the two are coming together, and we need to consider them in the round if we are going to deliver a sustainable future. Having said that, I've set my speakers today a task of trying to be upbeat. It's always hard when you have a UK audience and a UK panel to be upbeat, but we are going to be glass half full at the end here to try and end on a sense of positivity and energy around the fact that we can instill some change, even if it's not change overnight. So with that, I'd like to introduce the panellists that we have. We have Katie Wood, who is the Director of Operations at Arup, And whilst you might know them more around some of the buildings environment that we talked about early, Kate is actually responsible for the integration of people, process, and the assets that deliver better health outcomes. Great experience here in the UK, which she'll talk about, but also immense experience from Canada and Australia. So it might be useful to seek some insights around that. And an engineer by background, and I think that's hugely important because I think that gives us a different insight into process and methodology to deliver change. We have Ian Smith, who many of you, I'm sure, know is the Special Advisor to Four Seasons Healthcare, again, bringing that social care into view, was also the CEO of General Healthcare, which had 70 facilities under his management. But most interestingly, because I asked him earlier, he was part of the Middle East peace process alongside Tony Blair. And we think we've got difficulties here in trying to build collaboration and partnership. If there's anything that has been an entrenched problem for many years, I think, again, leadership and cultural sensitivities, Ian can bring some insights around that. And finally, Mike, which you prefer? Okay. I'll call you the Director of Strategy.
I'm Canadian too, so I can be upbeat with that.
Okay. Pleased to hear that. Well, Michael McDonnell, who is the leader for strategy at NHS England, and is really someone who can give us great insight into a whole new way of thinking, which is devolved responsibility, regional capabilities, population health, delivering care that is suited to a population and a region rather than a one-size-fits-all model, but also has international experience, having conducted some research and projects with Lord Darzi, who I know is very much aligned to this institution. So with that, hopefully you realise we've got some good people here today. I'd like to go to you, Katie, in the first instance, for you to tell us a bit about some projects where you think we're actually making progress, and if you can bring some insights to those projects that focus in on this aspect of cultural leadership. Who are the people? Where is the talent that is going to take us into delivering sustainable models of care?
Okay, well, I'd like to, I think I'd like to talk about systems leadership and some work. We've actually been working for 10 years with the NHS East Midlands Leadership Academy, which is, despite the heritage in the built environment, is absolutely nothing to do with the built environment. It's about the development of leadership capability within the NHS, and we work with them through the delivery of various different sorts of leadership development training and facilitation. We developed a systems leadership model. So, in other words, we talk a lot about systems leadership and the fact that it's needed more and more in the world, in the world that the NHS and others in healthcare are now experiencing, in order to work across the various organisational boundaries that we have. But what do we actually mean by this? What does it look like? What are the behaviours? What are the skills and capabilities needed in order to be an effective systems leader? And that model enables the development of those leaders to actually, be meaningful and achieve things. And as I say, it's been running for quite some time, and we are able to there's a wide range of alumni from the academy across the East Midlands, and we're able to bring in some success stories of how they have used those skills on real world problems, whether they're incremental change or disruptive innovation, and effect real change. Examples such as, going to the social care example, just either avoiding the admission or speeding up the discharge of elderly patients, and just adding up the number of bed days that saves, and that you can put a cost on that quite easily, and that is through someone at a sort of mid-management level taking it into their own hands to link up different bits of the system in a way that hasn't been done before. I mean, none of this is rocket science, but it just isn't commonly done because people aren't empowered. And so this model's then taken up nationally by the National NHS Leadership Academy, and there is some guidance out there. So I suppose I would, rather than we started the day talking about, at a real national health system level, I'm now going down to a real pointy end people who really are at the point end of this, and how we empower them to make a difference.
Okay, let me, I'm going to make 5 points briefly, and I'll go quickly through this. So, let's come back to it if you want to discuss it. And really what I'm interested in is system change and why we haven't had system change in the UK, and what I think we should do about it. And I'll use 1 or 2 examples from the social care sector to illustrate it. So I think there's little doubt about where we want to get to over 5 or 10 years. We want integrated care organizations out of hospital that wrap care around patients and manage patients over full cycles of care. And in hospital, we need academic health science centers, the first of which was here at Imperial, which my brother set up with his colleagues here. My brother was here this morning, but being a medic, he's got a very short attention span, so he isn't here this afternoon. And within those AHSCs, within the academic health science centers, especially with the rise of genetic medicine, a real focus on and making choices about areas of research to focus on, linking that to clinical practice and consolidating clinical units, because with the advance of biomedical science over the last 30 years, it's clear that scale is important and that it saves life. Secondly, that brings us to a puzzle. Why is it if we have outcome data that consolidating clinical units improves outcomes? And we've got a very good example at the hyperacute stroke unit in London, coming down from about 40 units to about 8, with 20 to 30% improvement in outcomes. Why is that still one of the few examples that we talk about through the country? What is it that prevents system change more widely? We hear about bed blocking. You'll be shocked to hear that throughout the care home sector, we have 5,000 beds empty right this moment. Right this very moment. So we know that there are frail elderly people, most of them living with dementia, suffering, dying more quickly as a result of being in acute wards inappropriately, yet we cannot get those frail elderly people living with dementia out to the care home sector, which will probably look after them as well or better than in hospital. And on top of the 5,000 empty beds, we're rapidly closing hospitals because the economics, the money is not there out of hospital. So we'll probably see 50,000 beds come out of the care home sector in the next 4 years. And there's only 100,000 beds in the NHS. So that's number 2. So why don't things change? Why, despite really committed clinicians and carers? Why? Because in spite of us having some of the probably the best biomedical science per capita in the world, obviously the Americans are ahead of us, but Britain performs incredibly well, and an accessible service that's free at the point of care. Why are we stuck in 1948 with largely district general hospitals, a distributed GP network, and really no out-of-hospital social care setting? And my belief is that it is a supply-side monopoly, and that good-hearted people, and I think Simon Stevens is a very good-hearted, smart bloke. I think Jeremy Hunt is a good bloke. But I think they try to form change. They try to bring about change by using supply-side mechanisms. And it's what you would do if you were in the system. You can reorganize. You can launch initiatives, new care models. You can increase regulation. And they are done regularly, year after year. And the sad fact is that they don't actually end up changing the system. There might be a short-term improvement, but they don't actually end up shifting the system from 1948 with an epidemiology of disease that was completely different in 1948 compared to the epidemiology of disease and social need in 2017. So thirdly, what I think you need are demand-side mechanisms. I'll just mention them, and as I say, you can come back to them. Firstly, we need high-quality public information on outcomes. Which units are producing the best outcomes in both health and social care. Secondly, we need real choice. We need to give this system back to the citizens of the country. They will discipline the system. If they are going to live longer and better by going to one provider compared to another, then they will do it, and they will discipline the system. And they are much more aware, much more omnipresent than regulators who try to do a good job, but are hugely stretched, of course. Thirdly, for that to happen, you do need competition. It's the dirty word in the NHS. It should not be. The only criteria should be which provider, public, private, third sector, men from Mars, which provider produces the best patient outcomes over a full cycle of care, at the lowest cost to the payer, which in our case is mostly the taxpayer. Fourthly, personal budgets. Until the money follows the patient, it will flow back into the hospitals and back into the GP practices, with a very small amount of money going into community care, which is where it flowed in 1948. And finally, of course, you do need expert commissioning. This cannot be a free-for-all. You do need scale commissioning, not 211 CCGs, STPs. Let's hope they do produce proper scale expert commissioning that can manage a market and manage over time to the destination we know we want to get to, which is ICOs, integrated care organizations out of hospital, academic health science. And finally, where I would start, we always start with sort of top-down, let's reorganize the service, let's have new care models. We should start, I believe, with vulnerable people right now. We should start with the 20 hospitals that have the worst delayed discharge, and don't just go in and solve delayed discharge. Take the 100 frequent flyers in each of those hospitals, or 50, it's a very small number. Put a package of care around each of those individuals and manage them through to end of life in the case of frail elderly. Rushing through, whether the local authority objects or the GPs don't agree with it or the clinical commissioning group doesn't agree with it. Real leadership that takes responsibility for people's outcomes, cohorts of individuals, rather than managing units, institutions, hospitals, care homes, or whatever. A similar example with Tier 4 camps, which is the acute end of children, adolescent health. There are only 1,200 in that category throughout the country, yet we have failed to put care packages around them, manage them over full cycles of care. Over time, we will get to the integrated care organization in 5-10 years' time. The 5-year forward view is absolutely right. That's where we need to get to. But we can't start with it now. We need to start by focusing on real vulnerable need right now, introducing the demand-side mechanisms I've talked about, and to end on a note of optimism, if we do that, we will transform our system. Yeah.
So Mike, very interesting, and I would love to hear why, with this development of the STP, the 5-year forward view, which has come from the centre, tell us why it will be different this year, and this time, and we're 2 years in. What are the successes to date?
So I'm going to come back to that, if you don't mind. I enjoyed listening to the Smith plan. I thought that was really, that was fantastic. I took some notes, and as it turns out, we're going to put out our own plan tomorrow, so we'll see how many of them line up. I just want to start a little bit with locating the debate in the innovation puzzle, as Ian put it, and narrow in a little bit of what we're going to say about innovation in that plan in particular, and we can zoom back out and talk about STPs or whatever other people want to talk about. I think the first thing I think to remember is that the NHS actually should play a greater role in supporting basic science, and this is not all, people think the NIHR is the only place that can do this. I don't think so. I think we've got to do more on that, and indeed we are going to do some more on that. So just to take a couple of specifics, by the end of 2018, we will have sequenced 100,000 genomes in this country. It's a major advance compared to other countries. We have taken more samples. That helps support the biomedical industry that Ian referred to. We've got to take, I think, greater steps to make clinical trials much easier to do in this country, and to make sure we continue to fire the industrial engine, which is the sort of pharma and biomedical industry in this country. We could do lots more on that. Harmonizing approval and recruitment processes, for instance, is something that we'll target and talk about more in the coming weeks. Secondly, I think we can do a lot more to foster real-world data, real-world testing on the way to getting to rollout. So we do too much, we think about the lab too much and too little about what the NHS, how the NHS should be testing technologies or new ways of delivering care in its actual practice. And this is partly, as sort of Ian hinted at, because it's quite hard to change lots of our NHS. And Junaid, who's up there in the back, has been helping us with one of our programs where we try to pair technologies with what we're calling test beds, bits of the NHS that want to move faster, that want to try to implement technologies alongside service change. There's some really interesting stuff going on in Surrey, for instance, where we're using wearables to help people get out of hospitals who've got dementia, stay at home, not even go to care homes if we can get away with it. But there's plenty more we can be doing to foster that sort of across-system experimentation and to get the sort of data that we would need to see it roll out a little bit more further. Also, academic health science networks and centers, I think, incredibly important part of our architecture, if we're being honest, still a little bit underdeveloped, and we've got a long way to go on them. But we've got to double down, I think, on that investment and see them as a way of testing, rolling out, helping industry and science connect with the NHS. And again, we'll be saying more about that in the coming weeks. And then to come to your sort of what this panel's about is there is a sort of paradox that on the one hand, medicine sort of races ahead, and there's huge transformational technologies and innovations every year, it seems. And yet the delivery system that manages them or delivers the care tends to go slower. I don't actually accept, as Ian said, I think too rhetorically, starkly, that it never changes. I think you can point to some important things. For instance, how a general practice is clubbing together in various ways, hard and soft, all across the country, I think is an example of an actual change that's going on in business models. You might argue it has something to do with the fact that they're not fully public bodies. But anyways, there are other business model changes like that. And I think it's too easy to just say no change has happened and all change happens in the private sector. Actually, we see great parts of the NHS making change happen, but not enough, not quickly enough, not widespread enough. Now, it is a supply side answer. I think we do need to do more as the NHS to innovate those specific delivery systems. So we started off with our Vanguard systems. Some of you may know about these. There's about 50 systems across the country. What we're trying to do is manage populations, try to reward those systems for managing populations, try to integrate services around the vulnerable groups and the older, frailer, likely to be hospitalized groups. We've had some good initial results from a number of them, much better, lower hospitalization rates, in particular amongst older people. And so now the time has come to accelerate that further. And one of the things we'll do tomorrow in the Stevens plan, as opposed to, will be to, for instance, announce a number of systems across the country where we're moving to accountable care systems, is what we're calling them. And broadly, that means something like what we're doing in Greater Manchester, asking them to take much greater accountability for population health, for managing within their budgets, in return for greater freedoms and flexibilities from the centre, to give them more control, but also to locate the debate nearer where the need is. And I think we can see in several parts of the country a number of systems that are really ready to go and make big change on this, around integrating services, integrating funding, beginning to horizontally integrate and work together between hospitals and vertically between hospitals and general practice in particular. I think we could be on the verge of a delivery system transformation. I do think we will need demand side pressures as well as supply, but we'll make a start from tomorrow. So I'll leave it there.
Thank you. The whole purpose of this conference is to look at business enabling that change. And I just wonder, from the point of view of perhaps Four Seasons and also our understanding the pressures on global healthcare and the complexities of different systems at different stages of evolution, how has the business evolved? How is business changing its mindset to work with different stakeholders, different vendors, different providers to deliver the care that is actually what's needed now, but also for the future? And if that change hasn't taken place, then I'd be interested to hear that as well. But have you seen the business itself think differently about how it structures itself and delivers?
Do you want to start, Katie?
I've got an example. I'm not totally sure if that's completely answering the question, but I think yes, we're in aid of definitely being positive and coming up with good examples. I think this looking at new partnerships around new models of care, I think it's happening, and I think it is despite what we've spoken about earlier about the rigidity of the system, et cetera, I think it is happening. I think there are people who are exhibiting signs of systems leadership and looking to make this happen. And an example that I'm personally involved in and Arup has been supporting through a bit of free time, if you like, because we believe in it, is a project called the Defence National Rehabilitation Centre, which is replacing Headley Court. There's a replacing Headley Court in Surrey that's underway. It's construction just north of Loughborough for the MOD. But what we're working with the charitable sector to see if we can bring into being as a parallel NHS centre. And this is strongly championed and supported by the East Midlands Trauma Network out of Nottingham University Hospitals NHS Trust. So you've got people at that level wanting to, and I was just thinking about the talk earlier on about disruptive innovation. I think this is an example of disruptive innovation because it really is looking to do something in a new way to achieve a different result, which isn't just getting people safely home, it's getting people to the point where they can go back to work, which has a very important result for our economy. So we are seeing shoots and examples of how, opportunities of how these new partnerships can come together. That said, we haven't got it off the ground yet, but I mean, it's an example of hope for the future, I think.
And you mentioned that the business is sort of letting you do it in your spare time.
Well, to a certain extent.
Sort of.
Yeah.
I mean,
yeah.
how open are they for you
Yeah.
as leaders within
Yeah.
the business to say, I'm really going to explore something that isn't in our core business offering?
Well, I think for us as a company, we have a slightly different structure in that we're wholly employee-owned, and that is all of the employees, not just a certain portion of them. And so, obviously, we need to stay in business, and the better a margin we can make, the more we can reinvest. So some of it goes back to us, the rest we invest again. So some of that investment goes to things like this initiative, which we feel strongly about.
Thank you. Ian?
Yeah, I mean, in general, though, I would make the point, I don't think it's really private and public. I think you can find lots of innovation in the public sector and lots of status quo in the private sector. I've spent eight of my 40 years in management in the healthcare sector, but in the private part, so most of it in other industries. And frankly, change in any organization is really tough. And there is a status quo, and I think it's less so these days because regulation has made monopolies much less widespread. But it's very tough to change normal organizations, especially if they are close to monopolies. I started my business career with Shell, and that was a real cartel, frankly, for about 20 years. There was no reason why Shell or Esso or the others should change. I think the problem here is monopolies, not public-private. And I think, I mentioned competition as an important way going forward. And I know Michael and Simon and Matthew Swindells, would probably agree with me on this. I think the challenge is how do we introduce competition into the public sector, actually. I think one of the mistakes that Tony Blair made, and I have to admit that I did work with him during that period and during his healthcare reforms, he did try to use the private sector with the independent sector treatment centres as the sort of nut to crack it. And it was a real mistake because, people just said this is people making profit out of it and they put up the defences in the NHS. It was, in hindsight, it was a real mistake. As I say, at the time I was all for it. In fact, Simon was one of the architects of it. So, we all look back and, we have to learn.
Was it really a mistake, though?
Yes, I think it was a big mistake.
Because
I think it
cut the waiting times.
And they've gone back out again, So, I mean, it got repelled and we went back to normal and the waiting times have gone out again. I don't think we've seen any long term. So I think the issue is competition. It comes back to the things I said. And I worked with Michael Porter for 10 years, actually, in Monitor Company and the strategy consulting firm. And I think Mike has got some, part of the answer here, which is information, outcomes. If you give that to people, they will act on that. The system will be developed. Actually, clinicians are, especially doctors, are incredibly competitive. I mean, if there's one unit doing hip replacements better than the next one, and that's public data, they will respond bloody fast because they are hugely competitive. And they want to do the best by the patient. That's why they came into the place. So I think the challenge is how do we create information upon which people can make choices and clinicians and clinical teams can improve and create competition so that people are really responding to customer need. Mike Porter's got a great example of transplant units in the United States where the worst had a 3-year survival rate, a 1-year survival rate. The best had a 1-year survival rate of 100% of this transplant unit, and the worst had a survival rate of 4%. If you give that information to patients, the people who pay for the system, of course they'll bloody discipline it. And the bad unit will either change or go out of business, and it should go out of business because it's getting people within a year. So I think the challenge is less public and private. I think it is much more about
how do we create competition, visibility, and then come back, as I say, it's so irritating reading the Financial Times, even last week. Money is being siphoned off of the NHS to go into the private sector, to do elective surgery. That's not the way we should be thinking about it. As I say, who produces the best outcomes at the lowest cost to the taxpayer gets the business, and whether they're public, private, or, and I'm sure, Michael, you'd...
Yeah, quite a part of how irritating that was. It was also factually wrong.
It was factually wrong,
which is even more irritating. Just on the kind of waiting times, I think it's interesting that you say there's no lasting change involved. I mean, when you were working, there was 18 months people were waiting for operations. Now 9 in 10 people are doing 18 weeks. So look, it's getting worse, but that is a major difference, a lasting one, right? Yeah, but so I guess the question becomes, when is the tool of competition to be used, and in what form? What are you competing for? So, is it for particular operations? Well, that feels like from an era where we had a lot of money and we had waiting lists of a certain kind. Now we're wondering whether we ought to be trying to create integrated care systems that might in time learn to compete with each other. And
what about the consumer as a driver of competition? If you give them choice, if you give them access, are they surely not going to be the ones?
Well, people keep saying that, though. It's interesting in this country that despite many pushes, and you might say they were misjudged or they could have done them better, it is interesting that still people would rather go to a hospital closer to them than one further away.
That's completely wrong.
Well, then...
Actually, I do work on this, and that's wrong.
Okay, so why do you think the demand side pressures haven't unleashed the...
And to support Michael, the Save My Local Hospital... The Save My Local Hospital... I mean, what Michael is also saying, the Save My Local Hospital lobby is extremely strong. And it's...
But this is a really interesting point, because this is where we want to go, don't we?
Yeah.
We want people to get into their heads that they'll get better treatment if they go to a specialist centre for all sorts of things.
I mean, I just want to make the point that actual proper econometric studies of demand have shown that clearly distance matters. This is a good to which you have to travel, to which your relatives might have to travel. But within that, we know that for a range of services, there's emerging evidence that patients also value clinical quality or measures of clinical quality. So it is not true that people simply, I think it's very outdated to think that people simply choose on the basis of car parking fees, access. Clearly people make repeated decisions, and reputation matters a lot in this game. But actually most of the econometric studies of Britain show that at the margin quality matters, and that includes work I've recently done on choice of GPs.
Yeah. Actually, inspired by Carol.
In
the same group, we repeated her study using national representative surveys in Turkey over a period of 10 years after major reforms. And what we observe is something very interesting. So initially, utilization of primary care begins to increase because healthcare centers are near patients. Again, we're using econometric models. But what we see afterwards is that primary care utilization continues to increase, even though the patients are able to access hospitals, public or private, without any gatekeeping. And what happens is that we begin to see a decline in hospital utilization. But what we see, because we're able to use the survey data, the utilization of primary care increases because perceived quality increases. So I think the behavior is a bit more sophisticated than what we are likely to believe. But there are not enough demand-side studies to really understand. But it's worth exploring. So distance is one factor, but there are many others. Users can be quite intelligent in the way they use the systems, but they need to be given the right kind of information.
That's really important information to help us make evidence-based decisions, because at the moment, the kind of orthodoxy we have from commissioners is about the local treatment, and it's really hard to get beyond that discussion.
Any other points from the? I'm conscious we've got about 2 or 3 minutes left. So any questions or points from the audience? You've got access to a microphone, and we'll get you one.
I was also a surgeon, and I worked in both the private sector for the NHS patients and in the NHS itself. I agree that lack of competition breeds complacency, for sure. But we also need to have a level playing field. Because if you present patients into the private sector, they're very choosy about what kind of patients they will treat and what kind of patients they will send to the NHS. So the patients who are more complex and will cost more will end up in the NHS. So there does need to be competition, but there does need to be some consideration for developing a level playing field for that.
I just wanted to make a short point about closer to home and specialisation, which is that although people might make individual rational choices about their own care, about whether they travel or not, when it comes to a general concept of closing an NHS facility down, like Hammersmith and Charing Cross A&E, for example, you get an almost insurmountable wall as a politician to do something rational. So there's a category difference of decision, and both need taking account of.
Yeah, but I think on both those, they say my local hospital lobby is massive, and you know, they're dangerous people because they are killing people. I mean, it's the evidence from the hyperacute stroke units. So I think we do need to give people information. I think the clinicians need to stand up because they are, you know, God knows why, but they are still hugely respected in the in society. You know, and they will be listened to. The Aradazis, my brother Steve Smith, you know, they have incredible credibility, but they need to stand up and
just
say
those
that.
two, yeah.
Just those two, all of them. I think, you know, and they need to stand up and be counted. And at the end of the day, you know, I think if all of that doesn't work, frankly, we are killing people if we don't do this. And you know, the leader does have to say we are going to do it on absolutely on a level playing field. But you know, back in the ISTCs, this was a risk-adjusted cohort of patients that were put out to the private sector at lower prices. I think anybody would do it if you were paying more because there is more risk. But it definitely has to be a level playing field. Yeah. Sorry, Michael, would you?
I agree with all that.
Justin Watling, so Population Health Management. I was just going to pick up a bit. I'm not sure whether competition is the sort of sole answer to it, but I was going to reflect on the Nuka Care model in Alaska, which is quite well studied. And actually for them it was about customer ownership, and they won't do anything without customer owners. Rather than a competition mechanism, actually they put the citizens in control of the system and worked very closely with them on the care model so that actually they were controlling really what was important or not. Yeah. So a very different angle that actually wasn't competition that solved it. It was a customer ownership model. And they have quite a nice graph, and I don't know how it's backed up by the evidence that was being mentioned earlier, but the plot, if I can draw it in the air, has at the sort of lower end of the sickness severity spectrum, the acuity, the customer ownership of the process is being very high, and the clinician ownership of how that care model should be very low. But actually, and that stays quite high until you get towards the very end when they flip over, and actually there comes a point when actually competition or citizen ownership doesn't really matter so much, they would argue, because maybe the patient's unconscious being right at the other end of the extreme, and clinicians need to work out what to do in that circumstance. I think it kind of reinforces very much that actually a lot of what can be done is around the citizen ownership of it, and I'm not quite sure that's necessarily the same thing as competition to solve.
Mm-hmm. Oh, absolutely, and you know, and I'm not a American libertarian, you know, who believes in this Wild West. So don't get me wrong. I think commissioning is extremely important. We need a managed market. We need proper regulation and so on. And there are some activities, probably A&E, you know, which are not competitive and don't have the scale to be able to be competitive. But you need a regulatory system of which competition is a part of the things I said: information, choice, personal budget, commissioning. It's part of that total pie. It's certainly not. There is no silver bullet. It is how those five things operate together, and how, you know, and the important point I do make, which, you know, I feel we really, and hopefully it will be part of tomorrow, is that we focus on vulnerable patients. If there's one thing we could really do in a healthcare system that could begin to bring about reform, it is to move from the idea that the hospital, the unit, the care home, you know, domiciliary care is the unit of operation, and to move from that and say, you are responsible for the patient outcomes of this cohort of people. You know, give me 100,000 people in Northwest London, tell me I'm responsible for getting them through to end of life in a dignified, you know, relatively pain-free way, working with them when they're living with dementia to give them the best outcome. If you think about it, it's a really radical change that from, you know, my career peaks when I'm a trust chief executive or or chief executive of the NHS or whatever, to actually I'm responsible for managing a cohort of 100,000 frail elderly people in northwest London.
I mean, that's exactly what's at the heart of population health and some of
It
these
is, yeah.
accountable systems that we want to try to develop. And I think it gets back to your points about systems leadership. Actually, this is the hard bit at the system level for us. Is we've got a bunch of people that have been brought up running trusts, being GPs, being orthopedic, being surgeons. Well, we need to get some people involved that want to break down those barriers, move beyond traditional divides, and that's actually an incredibly rare skill.
So with that, I think I will draw to a conclusion. The one thing I would say is that I think we are making progress. I think the UK was put up today at the very beginning of the session as something that we should value because it provides universal healthcare and it has value at its very core. And I think that is something that we are immensely proud of, and change is happening within that. But I think we also have to realise what we've learned about today in immense detail is this unbelievable wave of innovation. We are in a golden age of innovation, and that presents a very different pressure to the NHS. If the UK is at the heart of developing some of that innovation, the UK also has to be at the heart of adopting that innovation. And I think that is a whole new area of discussion, because what we're talking about here is delivering the foundations of care, but not necessarily delivering the next generation of personalised healthcare, which also has to be built into a system that is sustainable. So on that note, thank you very much. Thank you for joining me.
Thank you, Gabrielle, Michael, Katie, and Ian. A very great, sparky end to the day, I think. Right, now, I know you all want to rush off and get to the networking drinks. Thanks, Michael. Laura and I have been frantically communicating in whispers about what the key messages are from the day. But I think we've picked up a few themes that are sort of underlying the discussions. And I mean, the first thing to say is what I said right at the beginning, really, was that this was a bit of an experiment for us, this conference, because you normally get conferences which are quite siloed. You get pharma people talking to each other, you get medtech people talking to each other, health finance people, health policy people, services research people, and so on. And it's actually pretty rare to get everybody together in the same room. And I suppose about 6 months ago, I was beginning to think, this is going to be a complete disaster. Nobody's going to come. Nobody's going to talk to each other. But actually, I think the quality of the discussion and the level of interest and the fact that you all stuck with it, by and large, right to the end, in a very long day, is just testament to really the importance of this conversation that we're just beginning, I think. But just to very quickly turn to the common themes. I mean, I guess the thing that I picked up really was that, and it was just going back to Nick Peters' point at the beginning, Rifat's points about health system, it isn't really the money. The money's not the issue, both in terms of research and development and supporting the basic science, and of course we always want more money, but just actually a lot of money around. But also, money's not the issue in terms of either strengthening health systems in developing countries, and we heard a little bit about that from Jeremy Lauer, but here and in the rest of Europe, North America, when it comes to reorganizing the way we deliver care. And we know what we need to do. We know what a good health system looks like. We heard a bit about that from Mark Britnell. It is about organizational change. It's about new service delivery models, new business models, new players perhaps coming in. Technology is part of that picture because it enables change, but it's only one part of it. And the really big issue, I think, for me is actually, and again, just going back to the point that Mark Britnell made about this disconnect between different stakeholders and alignment of interests between different stakeholders. We have this problem, I think, in healthcare where we've got this immensely fast-moving science and technology base. You know, the level of knowledge about medicine is supposed to double every 5 years, or some people say it's less than that. Immensely fast-moving underlying science and technology pushing innovation in. But as Rifat said, this sort of archaic delivery model that we have, which is running up against, and Gabrielle mentioned adoption as being, and not just adoption, but implementation and sustainably embedding innovations in systems and organizations is the really critical thing. So how we deal with that misalignment in the pace of change between science, technology, policy, new thinking about service delivery, and we got a little hint of this from Ian Smith, you know, the long-lasting fixed capital built infrastructure, and Katie Wood, which is hard to change, and you know we rationally might need to close a hospital, but it's very difficult to do that. So I'm going to stop there. That's what I picked up from this. It's been a great day for me. And Laura, I think you've got some thoughts as well about what you picked up from it today.
It's difficult for me to come after James because James is the expert in innovation. So I've been thinking that I'll adopt a completely different approach and try to find one word that would summarize today. And I think one word that came back at all the different sessions is simply partnership. Partnership having the power of reducing our inefficiency of a healthcare system that is already in place. We're always thinking in terms of innovation, we're thinking in terms of future, but also partnership has the opportunity to, if we work together with the different stakeholders in terms of suppliers, payers, and patients, to reduce some of this inefficiency. Then, of course, we've seen the role of partnership in the context of R&D. We've seen that small structure as well as big structure like Nestlé need collaboration to grow. We've heard Pierre explaining the transitional research from discovery in a lab and how we can put it in the market. So the importance of all this partnership. We've heard Kassim talking about seeds funding, where they have a different approach, where they go and find the innovation that they think they can put on the market, providing their own structure and experience. I think then there is another aspect of partnership, which is the delivery of innovation, and Rifat has mentioned it quite a bit, and also from Rifat's work, Rifat discussed a lot the role of asymmetry of innovation and the problem between the innovation and the problem of implementing this innovation, and I hope I've said it correctly. And then finally, even when we talk about leadership, partnership plays a very important role. If we think of new models of care, I think all the different speakers have mentioned the role of partnership and that we need to work together, not in a simple public and private partnership, but in much more complex structure. So that was the word that I'm going to remember of the conference, and of course there are many other aspects, and and I hope you've all learned from the different perspectives today. So thank you very much. I have a lot of thank you actually to do. So I'll start, of course, with our fantastic speakers and their great contribution. I have to thank our management group, who have been very supportive, and of course all our health economics colleagues who have been very patient, very supportive, were always present when we needed them. We had a fantastic team to support the organization of the conference, so we were very grateful to the marketing and innovation team, including Ed, Maggie, Tim, and Claire. We had the events team with Funmi and Tamzim, who have done an amazing job. And Emily, you think I might have forgotten you, and you were maybe happy because you don't like being in the spotlight. But we have to give you a special thank you for your help, your support, your focus. You really made this conference go ahead and happen, so thank you very much for all your help. So we invite you now.
Any more thanks? No?
What to you?
And you. And I think just the closing words from our acting dean, Nelson Phillips.
Don't worry, I'm not going to say very much. Okay, I have some notes, but they're only like 2 words, so I'll just put them away. First thing I wanted to do was just thank these two. So a big hand for James and Laura, I watched them go through many iterations and ideas, and it was a fantastic job by them. And so great work. Thank you very much. I want to thank all the participants. It's been really great having you here today. Imperial, a huge part of Imperial is focused on health, and the business school shares that deep interest. So we made a lot of new friends today with you guys coming here, made a lot of connections, and it's really great that you took the time to come and join us to have this conversation. This has been a really terrific conversation. I think a lot of the conversations, your partnership word was fantastic. I think a lot of the conversations showed the value of bringing people together out from different groups that don't normally meet. Sometimes to disagree with facts, other times to bring in external kind of realities, and it was really fantastic. So thank you everyone for your participation and for bringing together all these different ideas and different thoughts. So that's fantastic. We are actually just about to announce the opening of a center, which has been mentioned several times today, a center for health research. So you'll hear more about that. So if you want to continue this conversation, that's a great way to do it, is to get involved in the center and come to some of those events and sort of be part of that. So we hope you'll all join in when we contact you and continue to work with us in this way. Okay, I think that's enough. I kept you from your drinks long enough. So thank you all for coming. I look forward to seeing you again in another event soon, and enjoy the drinks. Thank you very much.
To push, I've got one as well, so it's outside.